you all. Thank you all for coming today in the middle of a tropical storm. We planned that actually when the committee got together, started talking. We knew that today would be the most likely day that Hampton Roads would see some bad weather. So I'm really thankful that y'all made it out. We're going to do our best to make sure we stay on time throughout the whole day, which is why I'm going to go ahead and get us rolling now. I want to get you out of here by 3 o'clock. The worst of it shouldn't come until much later this evening. So if you got any worries or whatever, we will have lunch here. If you got a jet at lunchtime, I understand, but please stick around for the conversation if you can. That's actually the meat and potatoes of what we're going to do today, is the conversation that's going to be at the end, because we'll start to set some next steps of things that we need to do as a system to move forward. Wanted to chat just real quick about a couple of housekeeping items. Bathrooms, if you haven't found them, are just right outside this doorway. Men's on the left, women are on the right. There's breakfast over there. Please feel free to get up. It needs to get all eaten because we don't want to take it home with us. And there's coffee in the back of the room. If you need anything throughout the day, please feel free to let me know, or one of the Western Tidewater folks. We're definitely here. We can take care of anything that we need to do. We got a good list of presenters, so you've got your agendas up in front of you. Take a look at all of that and know what we've got going on. I'm really excited to get some things kicked off. Also, there's some name tags on the table. I don't like filling out the name tags either, but please do put your name and maybe the agency you represent on those name tags. And that way everybody knows who everybody is. I promise I'll put mine on too. It'll fall off of this jacket. They never stick. To set everybody's frame of mind, though, I brought out an artifact that we've had for a while. This is our spaghetti diagram. Those of you that have been in the CSB system for 10 years or more and in data management committees will be familiar with this. This was our initial attempt at trying to assess where information goes from CSBs to DBHDS or other state agencies. And it was the original diagram. I've had this rolled up in my office for a couple of years and thought it was an appropriate time to bring it out. You'll note some things in there that don't exist anymore. We've moved from ITOTs to Track It. We've moved from nothing to WAMs. We went from kits to something else to something else to something else. So there's a lot of things that have changed in here. And we're about to embark on what I think will probably be the biggest change that we've had in state reporting for CSBs and DBHDS that I'll probably experience in my career. Hopefully I'll be out of here before we do anything else that crazy. To get rid of all of this, right? And make it into something that makes a whole lot more sense, that keeps our staff from double data entering, that keeps DBHDS from saying, we don't know which consumer is in cars or which consumer is in on the ID waiver wait list and which one came in the CCS data, making sure that we can make those connections and hopefully at some point start to make better clinical decisions, because we get better at doing things that allow us to interoperate and share information when appropriate, when safe, when within the law. So we're going to hear a lot about what we've got available for us today. That's what we've tried to set up as an intro, and we're going to hopefully sponsor some more of this as we go on. That'll be part of our homework session this afternoon, is to talk about what else do we need to do as a workforce in information technology, data, and analytics to keep us prepared as we move forward. So if you get a second, I encourage you to come up, take a picture with this. You can take a selfie with the spaghetti chart. That way you can say you were here when that was there, and that we made that whole thing go away as part of the work that we do in this room. Let me see. I don't think I had any other housekeeping items. So if there's anything that you guys need, like I said, please feel free to let us know. I'm going to go ahead and get us kicked off. Jenna Loy, who is from Fairfax Falls Church CSB, or as I like to call it, the independent state of Fairfax. She will come up and get us an introduction for this first presentation. It was special order from her, actually, the tropical storm. She's had multiple vacations ruined, as I understand it, this year due to natural events. And so you guys can thank her as she comes up. So give her a round of applause for coming.
Okay, so I'm here to introduce Steve and Jacob, who have been working on our data platform, or data warehouse, I should say, for CSB. We decided this year that we absolutely could not continue with what we had, and we wanted to put together a data warehouse. We did it for a number of reasons. Just to give some background, we have over 20,000 individuals at Fairfax Falls Church served a year. We have a lot of competing stakeholders for our data, from external sources and internal sources, multiple boards, multiple cities that we report out on who we've served. and the different services they received, et cetera. So between these competing stakeholders, we needed a better way to do things. We had to do a lot of research on what was available within our county and what was permitted for us to use. Our county is a Microsoft shop, so Azure was really what we had, and they had not done the tenant build out yet for individual organizations within our county with Azure. So we had to work that with them. And we needed funding. So we had to go through and figure out how we were going to fund this. We used a HRSA grant to, just to give a little bit more background, we have at least 21 data sources, probably more than that. We also, prior to this, were doing a lot of things manually. We had no centralized data storage. We had a lack of standardized data formats, including our EHR tended to change their data formatting every once in a while in certain fields, so that was complicated. Multiple versions. So we would do things manually. We'd create one version, and the next month we'd do it manually again. We'd create a different version, keeping all of that in place, synced up as best we could. Just in general, complicated, manual, no standard format process. Lots of flat files. We get information from grants via flat files. So just how do you keep it all in one place, organized? Yeah, and then we ended up being the first cloud-based data warehouse that was implemented within the Fairfax Azure tenant for our county. So that was a big deal for the county working in conjunction with CIT to follow their rules. So I'm going to kick it off to Steve and Vega to kind of go through what they have to do.
My name is Steve Mulcahy. I'm the one of the things that Jen would like I'd like to start our discussion. Contract. Bring in two great things. Bring yeah. So about this resource, if testing. Okay, so now I don't have to yell. I can talk in a regular voice. Thank you. Next up is Azure. I'm sorry, mission-driven data. Mission-driven data provided us the Janet tool, which is a critical component of our data warehouse. The Janet tool allows us to extract specific EHR data from our EHR system and migrate it to our staging database. And again, in our architectural diagram, we'll get a chance to see how that actually plays out. Metadata management. The documentation on the metadata for all the files involved with this project were not consolidated. They were scattered throughout our agency and across all of our different vendors. This information includes such things such as data dictionary, architectural diagram, standard operating procedures, et cetera. JAGA has been working diligently over the past several months to pull all this information together in a central location, and he'll talk more about the metadata in just a few minutes. Power BI. Power BI is our preferred report development tool within the county. But our agency really has not been able to deploy Power BI effectively on our EHR data because we are not able to connect directly to our EHR database. So that has presented some issues. With our database, our data warehouse, we hope to be able to provide more easily better and more robust reports, more interactive reports for our users that pulls from a single centralized database to provide them more updated information on a regular basis. Without further ado, I'm now going to turn the presentation over to Jaga, where he's going to talk about our approach to the methodology for this project.
Can everyone hear me? Thank you, though. Thank you, Steve. So since we have, based on the results from our high-level analysis findings, we could have, the next following task is first to find the right, right methodology or right technology to implement the data warehouse. So looking at a couple of factors like observing the data, inventory, data sources, we are getting the data from, and the consumption rate, and also considering the future growth of data. We want to be readily available for the next gen data. For that, we could have choose. There are 3 different technologies available in the market currently. I think everyone heard data lake, lake house, and warehouse. So for us in Fairfax to start the program or the processes, we chose to go with Azure Data Lake. Azure Data Warehouse, not Lake. So to implement that, we had to choose several different methodologies. One of them is 2-tier architecture. What is a 2-tier architecture? It's basically including a staging area where we can store all the data before the data warehouse layer. So confirm the data before we present it out to the user communities. The 2-tier system that need to be considered here is there are 5 points that we need to consider for this data warehouse. One is consistency, centrality, access and security, auditability, and last not least is data sanitization. Consistency is basically to make sure, since we are getting a lot of files from all different various sources, like different types, you have files from CSV, text, name it, pipe and stuff. So we are confirming that into one level. We are making them into one format, and it will be which is easily turned into proper to store it into a data warehouse. So the centrality comes in is as I mentioned in a single repository where the data for the organization is available in one location instead of scattered around the town. The third point it's to be considered for this is access and security. Basically, data access and security critical aspect of a data governance. Should not hinder. Basically, this policy should not hinder the user access. It should be simple and straightforward. The next thing is auditability. The auditability is basically to protect the data integrity and controls for roles and responsible who are allowed to extract or who are allowed to consume the data. Also utilize the technologies as available, like encryption, data masking, to make sure the system is well protected. The sensitive data is not being hacked around. So this is all necessary. And the last but not least is data sanitization. Data sanitization is an important point which should be taken into high consideration. Poor quality data will end up in a data warehouse failure. So I emphasize a lot on this phase to make sure the data that I'm receiving from all different kind of sources gets in and it's reasonable and it makes sense for the end user. Now, after choosing the methodology, now I have to see the decision, the design decision. A couple of things, as Steve and Jen was mentioning, Azure is a platform that Fairfax has it. So we utilized what's available for us. So that approach was easier for us to implement because the system is set up. We are the first one going in. So we are basically being the pioneer for this in Fairfax County, so we can show to the other departments. So another thing is to choose a system which is robust and scalable. Not only just going by cloud, you can choose different cloud system, or you can choose on-premises. But choosing cloud has a reason behind that. We are currently using data warehouse. In the future, we might jump in with as the data grow. We might go into next gen technology like lake, data lake, or data house. So in order to support that, we should have the ability to scalable and elasticity capabilities on the database. The third point is to automate as the process. We want to spend less time on confirming the file, loading the file. We want to automate as possible. So Azure has this tool called data orchestration tool called ADF, is Azure Data Factory. So we utilize whatever tools available to implement our automation process. The last one is basically security and availability, which is more important. Data in the cloud, always risk. So we had to make sure the protection is up. And also the encryption is implemented, the right backup is being done. And since it's in the cloud, we have built-in high availability and disaster recovery. So even the power went out, you still have data available in the cloud. So comes design. So this is compared to that spaghetti, this is the design that I came up with, and I showed my team, and they're like, what are you talking about? So you have sources, you have a warehouse, and you have an output. Actually, not that one, though, just trying to pull you guys like, this is the design. So simple, we have a source, we have a environment where we have all the application, and the final output where the consumption is going to be happening. So on our sources, we have Qualifax Credible, which Steve was talking about, MDD data, which is basically, it's a database copy. Though. So we have set up a SQL server in our Azure environment to make a copy of the data on a daily basis. So make it available for us. The other part is we have a lot of sources coming from. We have vendors sending us a file. We have a local departments also having a file in the network. So we established a centralized on-premises storage, and then utilizing the county's SFTP protocol and process, we able to move the files directly to a blob storage in Azure. Blob storage is just a storage to store all the files, right? And then based on the two sources, we have ADF, which is going to be orchestrating. First, we check the file is there, and then we make sure the file is being loaded to the data warehouse, which is eventually can be utilized by the downstream system, by the users. They can use Power BI, what we have right now running in Fairfax County. We have Excel. People are using Excel, can connect to Excel as well. And also any tools that have ODBC or JDBC capabilities to connect to this data warehouse. Taking into consideration of future. So I already have the things like we were supposed to go using Azure Synapses, right? If we need to add Azure Synapses as part of this data platform, we can easily turn on and have the connections already. So it's already available when we need it. We can just turn it on. All the groundwork, all the framework has been done. So anytime we need it, we can just turn it on and move on with the next generation data, as I mentioned here. And the bottom piece is all the flows. Like you see number ones, number two, number three. That's just basically to show the flow of the data, how it goes in there. So next continuation with this. Once you have the architecture design, you have to consider a couple of things though. The main important thing is standard operating procedure. You have a warehouse, you have to have a set of rules. If there's no rules, policies, anything can happen. So people will be doing different kind of loads and stuff like that. So you have to give them some guidance saying that if you want to load an Excel file, you have to put it in this format and then confirm it and then move it to a warehouse. Another helpful tool is knowledge-based article, which is very, very important for all the users in counties or anywhere, because you present a data warehouse, what is that? So people doesn't know how to use it, how to connect it. They will be reaching out to you. So it's good to have a diagram or documentation with the images, like how to connect, how to access a certain data, and make it available for them to use. The third one, which is part of metadata repository, data dictionary. This is a very important piece as part of the data warehouse. you have the data, but if you don't know the name of what's the meaning of the data, is useless. So you have to spend some time, even though sometimes hard to gather data, information from people. You have to make sure it's an ongoing process. It's not going to get done in one day. It's a continuing process because you as you get more data, more meanings come in, more entities are being added, more objects being added. So you have to get the rightful information, which is going to be helpful for your future needs. If folks retire, folks win, let's say, for example, Steve wins $1 million and he leaves, he won the lottery. Nobody knows what data we are working on. So we have to make sure someone who's coming back, who's going to replace them, they know what they are talking about, what is data. And then, as you know, architecture diagram, which I showed you earlier, that actually helped me to visualize, okay, where I want to go, like basic architecture, right? If you want to build a house, you need to have a framework, the same thing with the data warehouse. You have to make sure you have all the right tools in right places, how you want to join, how you want to process the flow. Now, here comes interesting part though. Not every process goes smoothly. There are going to be challenges. There are going to be learning curve. So at Fairfax, I had some, when I began the project, I had some issues with the architecture. It could be due to it's a new environment, how to implement a cloud. They were not a proper blueprint, not a proper blueprint, but they had a blueprint, but it was not satisfactory. It was not satisfying my thought process. So I had to work with the team, redesign the architecture to make sure, taking into consideration, what are you trying to achieve? What is your use case? What is your final goal and what is your future needs is. So doing that, that took us some time because you had to work with the IT and you had to explain your point of view and they had to explain their point of view. So it's a ongoing communication with them. So finally, they agreed with the design that I came up with and we implemented that. Second part, which we had ongoing basis is the network changes. Because due to this is a cloud, and DIT kept changing networks, they're adding more firewall rules, more security policy. Sometimes I do have, in my connection, all of a sudden, my connection to the Azure data warehouse gets disrupted. And people are pinging me left and right. I say, what happened? Why my connection is not working? And we check, look like something that they implemented the day before caused the connection disruption, though. So the one thing I learned from there is communicate, make sure they inform you what they're doing so that you won't run into this kind of issue. The third one is, this is kind of interesting because I worked in AWS, any storage unit, you can use SFTP process to go in. In Azure, what I learned was that the current blob storage, there's two types of blob storage there. One is just a normal blob storage. Another one is called Gen 2 blob storage. So we went with normal blob storage, assuming that SFTP process can work. All of a sudden, they came back and said, no, that cannot work. You need to upgrade to version 2. So that we had to end up actually not moving that much file, but we had to end up sending a different architecture. I had to do a lot of different other paperwork to get that thing done. I'll pass the next one to Steve to talk about the challenges on the business side.
So another of the challenges that we faced during our data warehouse project was the ability to import large quantities of our EHR data. This is kind of there's two parts to this challenge. One is that we were not able to migrate incrementally transfer new or modified records from our EHR database into our storage database, what we refer to as our Janet database. This is because we are unable to reliably identify which records have been updated or added to our database every day in our system. On the other hand, the size of our EHR database is so large that it's not feasible to transfer that every night. This is where the Janet tool from Mission Driven Data came. The Janet tool uses web services to allow us to extract specific data from our EHR database and migrate it to our storage database, which we refer to as our Janet database. Some tables are extracted every night. Some tables are extracted once a week, some once a month, based on their size and how often that table gets updated. We have processes of extracting data every night that currently run about 3 hours each. Relevant and necessary data. We want to keep our data warehouse database lean and trim to maximize reporting performance. So what we needed to do is limit the data that appears in our data warehouse. This has proved something of a challenge to our report developers because they're used to having the entire EHR database available for all of their reports. But this activity has forced us to really focus on our reporting needs and identify specifically what data needs to be available in the data warehouse for reporting purposes. We're still working on that and discussing with our report developers. The timeline for implementation. This was another issue. As you mentioned, we got a 12-month grant from HRSA. We were able to get a 6-month extension, which has been proved invaluable. For the extension was just for the timeline of the grant, not for additional funding. And we also got a late start on our project due to the funding notification date. I think there was a delay in that. Retrofit. This refers to modifying our existing Power BI reports. We have a handful of Power BI reports that pull from our EHR database. But right now, the data source for each of those reports are independent, standalone Excel spreadsheets that need to be updated manually by our staff every day, week, month, et cetera. That takes time and effort. We hope that with our data warehouse database, we can provide better reports from a central data source and also provide our users more updated data on a regular basis. Another challenge is data cleanup, which always occurs within data projects. As Jaga mentioned, this is just typical sanitizing of data entry issues. One of the issues that we encountered involved the pipe character. One of our vendors who provides us a source file every week was using the pipe character as their field delimiter. We soon found out that the county users of that vendor's system were entering pipe characters in notes fields as they put in their notes. This, of course, disrupted our automated process to migrate the data from the vendor's file into our data warehouse. We worked with the vendor, we talked to our users, and we hope that we've mitigated that issue at this point. Historical data. Our EHR database is a transactional database, which means it's optimized for fast record inserts and updates. It's also designed to reduce data duplication. Excuse me, data duplication. This process, this type of model, kind of hinders our ability to track historical changes to our records over time. A data warehouse database, on the other hand, is designed specifically for reporting and analytics. So that allows us, for instance, to be able to track client addresses before 2013. There's a list of just some of the challenges we encountered during our data warehouse project. Now I want to address some of the enhancements we see for the future for our data warehouse, starting with additional Active Directory security. We plan to manage access to our data warehouse with Active Directory groups. Right now, our handful of users to the data warehouse are allowed access based on their username. That is not an efficient way of managing access to the database when in the very near future, we plan to have dozens, if not hundreds, of additional users. So we hope to migrate to Active Directory security groups to make this whole process more automated and more secure. Dynamic data masking. Jaga mentioned this earlier. We're working on protecting PHI, PII, other sensitive data in the database based on users' roles and requirements so that only the users who need to see that sensitive data have access to it in their report results when they run the Power BI reports. EHR agnostic interfaces. We envision modifying our processes and our architecture to be able to integrate with all other future systems that are brought into our agency. Those are some of the future enhancements for our data warehouse. The current state of our data warehouse includes more than 31 tables migrated from our EHR database and many more in the pipeline. That represents over 1,600 fields within the data warehouse. We have migrated 4 views from our EHR database into the data warehouse with, again, many more in the pipeline. We currently have over 13 automated Azure Data Factory jobs running to transform and load our data from our staging database, which we call our Janet database, into our official data warehouse database. We currently have about 10 users in our data warehouse, primarily report developers and administrators at this point. In the very near future, we are going to have dozens again, if not hundreds. So we want to be able to provide them access so that they can see the data from a centralized location on a regular basis. And finally, the Power BI reports. We are working on converting 20 and many more reports from those standalone Excel spreadsheets to the tables in the data warehouse. That's an overview of the current state of our data warehouse. I'm now going to turn it back over to Jaga so he can talk about some of the lessons.
Thanks, Steve. So as I just want to keep it short for this one, one of the main important thing that lesson I learned with this organization or any other organization is you need to have a transparent partnership with your IT organization. They're very critical for you. You have to be always in communication with them. Any changes you make sure you inform them. Any changes they make, should inform you. So it's supposed to be a vice versa kind of relationship. With that, strong and consistent, you can get your project done much quicker and much faster without any hassle in between. The other thing is you also have to have a good communication with your vendor, technology partners, like your client, vendors. Even though you're basically they're servicing you, but you have a good relationship, good rapport with them. Anything that we need to make a change, they're not going to come and say, "Oh yeah, you need to pay extra to fix this." So they can do it on a basis of the issue is though. The third and most important thing is identify your reporting and your use case needs early. Based on that, you can design whatever technology you want to bring, whatever you want to go with. You can go with SQL, you can go with Spark, name it. So it's important to know what are you trying to reach at the end of the day. So that's all I have on that. So any questions? It is working, man. We just kept it just for the humorous purpose, Thank you, guys. Thank you, folks. Sure. Simple thing everywhere. You have teams. For example, you create a group. You add the folks work with them. Like people coming to group. So check always out. Another thing is always like just send an email saying that alert very high. You need to resolve this. And then the more you talk, the more you build a relationship, like a friendship, they'll help.
Another thing that Jaga implemented that's been very helpful for us is having status meetings, even if they are 5 or 10 minutes, 3 times a week, Monday, Wednesday, Friday. And we have some of our IT partners and our IT contacts invited to those meetings. They don't always attend, but they at least are invited to meetings to get a sense of where we are in the project, any issues that we're currently dealing with, and hopefully address any questions that they might have as well.
Weekly. So I do tend to send the weekly status so that it shows what I have accomplished, what my impediments are, what I'm working on, so that it'll give a good visibility to the team as plus with your partners though. So they will know that, hey, he's going to implement a new tools in Azure, so be ready for that. So that helps us a lot too though. Sure.
Good point. The question was about the tool, our EHR transfer tool, migration tool. It is called Janet. That's the name of the tool, and it is created by Mission Driven Data, an organization out of Oregon. And we can provide you a lot more information about that organization and that tool if you want. Sure. Question.
It's not Excel 7. It's not Excel. Sorry, the Fire type file though. It's just basic database file. It's a flat file. So what happens is there is a program that we run from EHR. It automatically transfers into it's a VB, basically I think Visual Basic Script, right? They run something like that. They have a Visual Basic Script plus some I think JSON, some script they involved, which pushes to a SQL database single instance, and then from there we move it to the warehouse. So we have a staging area before we move it, and it's not the file we get is basically a database file. It's a flat file.
Right, yeah, right now, our database, our data warehouse is designed primarily for reporting and analytics. I think the next step might be then taking some of that data and, manipulating it, transforming it, and then feeding it into other systems, not only within the county, but also throughout the state, DVHDS and state performance contract and things like that. Right now, our focus is on reporting and analytics, but I think that's a logical next step. Yeah, here, behind you. Yep. Good. The question is, how often do we refresh the data in our data warehouse from our EHR system, and how do we detect what data to refresh? That is a very good question, interesting question, one that we grappled with. The Janet tool for mission-driven data uses web services to connect to our EHR database and transfers entire tables at a time into our staging database. That tool, because our EHR system, as I mentioned, does not reliably track records that have been updated or entered into the system each day. So we can't pull specific records from the tables. We have to pull the entire tables, the entire client table, the entire employee table, the entire service table each time. And again, the size of our database is so large that we really can't pull the whole database over every night. So we've come up with several different extraction programs. Every night, for instance, the client table is updated. Every night, our service table is updated. Those tables that get updated every day, those are updated every night. And again, that's a 3-hour extraction process. Other tables within the database are not updated quite as often, or are large enough that they almost require their own separate extraction process. Some of those are the ones we run on either a weekly or monthly basis. So we kind of break down, we prioritize which are the most important records that are updated that need to be updated into our data warehouse database and pull those over on a nightly basis. And then the less important or the larger tables we do on less often. Good question.
So the question you were asking, we have built a framework for doing SCDs, slowly changing dimension. It's available right now, but unfortunately the use case, what we tried with a couple of tables, but then for the reporting needs, we couldn't proceed with that. So we have the framework built. So if there's available any other data in the future, we are still receiving a lot of data sources. Once we get the right appropriate data sources, we are planning to do the incremental and SCD type 2, type 1, depends on the case. Yes. Very good question. Very good point. In Fairfax, they are basically a Microsoft shop. So I think they were in Power BI already though. But with Tableau, I worked in Tableau before, with the servers Tableau, you can still connect to this is a data source, right? So you just need to have the right ODBC connection and you just logged in and you're done. No need to change.
And that's been kind of one of the key drivers for our data warehouse is making our data more accessible to more and better reporting tools. So it's not locked in our EHR any longer. Now we can, now as in a SQL server that we have more control and more access to, we can use Power BI, Tableau, Excel spreadsheets, almost any other reporting tool to connect to the data and create the reports in the tool that we choose, not the ones that our EHR limits us to. Question, hang on a second, Brendan. Excellent question. The question is, how are we connecting all of our various 20 plus data sources? Right now, that's what we're struggling with. That's what we're starting to try to handle. We've been concentrating so much on getting this data into our database. Now, from the report development standpoint, we need to start working on getting these data sources to work together. And our report developers haven't really started with that process yet. But that is definitely the next step over the next several months. Good question. Yep. Question? It took quite a bit of manipulation. We were able to essentially we copied the syntax of the view, the SQL of the view, recreate it in our data in our staging database, in our Janet database, essentially. Make sure to connect all the tables. We then recreate the view in the staging database, and then create then through the Azure data factory process. We recreate the view and thus a table. We also create the table in the data warehouse as a source for our report. So yeah, we essentially recreate the wheel. Correct. Yep. One more question. Yes. Yes. It's yeah. The Janet tool, the question was, can the data go both ways, back and forth between our EHR system and our data warehouse? No. Our Janet tool, the Janet tool is a one-way tool. It extracts the data from the EHR to provide it to us in our data warehouse structure. So unfortunately, we cannot update our EHR database, from changes made in our data warehouse. Good question. Brandon and Kate, that's all we have time for. So thank you very much, everybody. Appreciate your time.
Thank you, gentlemen. All right, so thank you guys. I really appreciate that time and really good question and answer. Glad we got to have a little bit of discussion about that. Please feel free to bother these folks while they're still sitting in the room. If you have extra questions to ask, interrupt them while they're getting something to eat, right when they take a drink of coffee, any of those kind of things. Again, thanks for your attention there. We got a break coming up after this next one, so hold tight. But if you need to step out, restrooms are in the back if you didn't hear my announcement earlier, and we still have some food out there, so make sure you grab some. Our next two presenters are Nicole and Marcus from BHI. I got a chance to talk to them a little bit about their introductions earlier today. So I didn't know this, but Nicole is actually the person that developed and created the Segway, the scooter that you're on. And really excited for her to maybe demonstrate that during her presentation. Marcus was talking about some of his summer events, and he is the new international axe throwing champion. So just congratulate him on those things. And together they have, if you guys seen the movie Moneyball, that data analytics platform for baseball was actually developed by these two together. It was their brainchild. So without further ado, they're going to come up here and tell us a little bit about BHI and some of the great work that's done there.
There we go. So yes, fun fact about that actually, BHI just actually went to the axe throwing place in Richmond but I'm not a professional. Done it twice. So yeah, so yes. So yes, my name is Marcus Divers. I am the EDCC Program Manager or Emergency Department Program Manager at VHI. And then Nicole, do you want to give a quick introduction?
Yeah.
And so just a quick show of hands, who has heard of Virginia Health Information before? Okay, good. Yeah, good mix. Yeah, exactly. And then what about the Emergency Department Care Coordination Program? About the same number. And then all payers claims database. Perfect. That's why we're here. So so awesome. So kind of to go off of that, I'll go over a brief introduction of who VHI is as an organization. And then we'll go over what you likely know, which is that EDCC program. We know a couple of CSBs in the state already participate that. So I'll probably go over that quickly, probably try to share a couple things at the end of things you might not know about the program around reporting and compliance and whatnot. And then Nicole will go over some of our other data service programs or administrative programs like the All Payers Claims Database. So to start off, what is VHI's mission? I will be really frank with you. If you go to this website, you will see our mission statement. We are in the process of changing that up. So if you go in like 6 months, it might be different. But yes, hopefully it will be different. It is, if any organizations have gone through the process of reevaluating their mission statement recently, you know, it's a long drawn out process. You want to get everyone involved. But it's been a good process thus far. But I will say the translation up here is likely to stay the same no matter what. We're still here to really break down walls and open channels to just help share healthcare data across the state of Virginia, supporting people in transparent reporting, and also doing that in an unbiased, collaborative way with all of our stakeholders. So how has VHI evolved? We've been an organization since 1993. We started with what's called our patient-level database or data system. And since then, we've picked up a couple other programs for the state. So we are a nonprofit organization that's been in the state since 1993. So we're actually celebrating our 30th year anniversary here in the next couple of weeks or this year. We do have a board of directors, and a lot of our programs that we administer also have their own advisory council that made up of different stakeholders. So EDCC has an advisory council made up of about 20 members. I think our board of directors is about 20 members as well. And then the All Payers Claims Database has their own kind of advisory as well. You can see here, we picked up the All Payers Claims Database in 2013. In 2017, we actually started administering the Emergency Department Care Coordination Program, or that's when it was established. And then we actually became the official administrators of what's known as Connect Virginia, or the state's designated HIE in 2019. And so, as you guys probably know, 2019, since then, there's been a lot of stuff going on. So yeah, so kind of learning along the way, and also kind of more on like the broad background of VHI. So we, like I said, we have a variety of different data sources that we have available that different stakeholders across the state and in other states actually use. You can see here some of the reports that we publish, that including the avoidable ED visits. We also have healthcare or health system parent company financials on our website. We publish charity care dashboards as well. And then a couple of our other things that we do is supporting others in basically just being the data source that they try to do research as well, whether that's through with VTHI, another organization in Virginia, to publish the health value dashboard, or also other academic institutions across the state. Fun fact, I saw not a lot of other people knew about the All Payers Claims Database, but when I actually interviewed for VHI, I actually found out that in some of my previous work at UVA that we had used a data source from VHI that I didn't even know about until I interviewed with the company. So totally makes sense. You might have used something that VHI has published in the past and maybe not known this is where you got it from, or maybe seen something on someone else's website where it says data has been provided by VHI. So now I'm going to go into what you guys do know, which is the Emergency Department Care Coordination Program. A lot of you guys have probably heard me or seen this slide before. give this kind of ordeal, but what the EDCC program is a statewide technology solution that helps connect hospital emergency departments with other providers across the state. Like I said earlier, it was started in 2017, mainly to help reduce the overutilization of the emergency department for non-acute services. And since then, it's really been transforming into more of a care coordination platform. So there's some other focuses outside of just the emergency department. We use a technology vendor for that called Point Click Care, who offers basically a network of similar programs across the country. And basically what we do is get what's called an admission, discharge, and transfer fee from the hospital emergency department, and basically use that to provide notifications and alerts to other providers across the state when one of their patients basically arrives in the emergency department. We also get inpatient information as well, and all at the end of the day to improve the quality of care for patient services. You can see off here that we have several CSPs. 14 are currently participating in the program and live. We have 3 going through implementation, and I know I'm probably talking to a couple more. And then also, this is a state legislative program, so actually all hospital emergency departments in the state of Virginia are required to participate, and also all health plans. So that's kind of our bigger users. Is a lot of the Medicaid MCOs will use this and input information like care plans or just follow up on their patients that are high utilizers of the emergency department. I will say at this point, if you do look in LIS, the Legislative Information System, there's a bill that just passed that is renaming the EDCC to Smart Chart. So you also might see it in that if you look up it in LIS. We work really closely with a lot of the state departments here in Virginia and other associations like BHHA, VHP, of course, DVHDS. I want to shout out, I did get to put the new logo in there. So for you guys, we're also, yeah, exactly. We're also, again, mission statement, and we're also redoing our logo too. So I appreciate you guys did all the work to do that. So I wanted to make sure I got that in there. And then also DMAS, VDH. So basically, kind of like I said, how the program really works, or kind of the top use case would be a patient has a hospital encounter. So they arrive at the ED, someone registers them in the emergency department. That information is then transmitted via PTC to their kind of database where they match it up with what are patient roster files from other organizations, whether that's the MCO or CSP, to basically match those together. There's a couple of different criteria you can choose to be alerted on. And so what they'll do is after they match those up, look at the criteria and send that alert out. Where you can respond in real time. We also have a lot of people run different reports, especially thinking over the weekend, you might have 50, 100 different patients that arrive at the emergency department. You don't want to be receiving those alerts over the weekend. You can also pull reports on Monday morning or at the beginning of the day. Here's kind of our base set criteria that we've kind of worked with our advisory council at EDCC to establish and kind of work off. You'll see a lot of them have to do with that, like I said, emergency department utilization. But there's also other things like we have flagging in the system where we work with Virginia Department of Health to get multi-drug resistant organism lab results. So that basically like flags that patient in the system so you can choose to get alerts on just those patients that have MDROs. We also have about over 180 skilled nursing facilities participating in the program by supplying data as well. There's also specific alerts around different conditions like opioid overdose and mental health behavioral health diagnosis. This is just like a quick screenshot. Hopefully everyone can see it okay of what the platform basically looks like. So basically by participating, you'll get access to the Point Click Care or EDCC portal. And here's like a quick overview of what some of these, what we call cohorts or groupings of criteria look like in the platform. You can also set, like I said, set it up to get alerts. So basically what it looks like is either an email or a text message with a link to log into the platform if a patient meets one of the criteria you got to decide to cut on. And this is kind of how an overview of what the data processing looks like. You can either choose to upload your patient roster file. So that's how we basically verify we only give information to providers that already share that PPO or payment or healthcare operations relationship with that patient. There's not like a queryable system where you can just look up a new patient. Anyone you receive alerts on or see information on has to be on that patient file that you upload to us. Depending on your capabilities as an organization, there's a couple ways to get that file to us. You can either upload that manually in the portal. You can get that through an automated SSP. Point Click Care also has different API ways, or you can set up a feed if your EHR actually offers that. So that's how we work with our emergency department. And for those out here, here's a sample of what a client file might look like. Where we basically need a minimum amount of information to do our patient matching. And then there's also additional things that you can include on there about who's a member of the patient's care team. If you have case managers or caseworkers working with that patient specifically, you can include their name, role, phone number if you would like, they would like to contact them when their patient arrives in the emergency department, especially for those complex patients. And I know with the TSP realm, there's also this idea of what the consent file. So for those that are offering the services covered under 42 CFR, we also have a way to basically put in your file patient consent. So there's kind of two different ways that you can set up your portal. One being like consent enabled portal, meaning basically if you do not have a yes on your file, we're just not going to show that information to anyone else on the platform. You're just going to be able to see their emergency department visits, like because the ED visits aren't covered. Or if you were you could also split it up and have basically two separate portals for your patients or clients that are serviced under 42 CFR conditions versus those things. Quick overview of the onboarding process. Basically, we usually go through and receive what's called a discovery form. It's just a form that gives us your information, basic contacts for IT, clinical. We have a legal agreement that needs to be signed as well, the signatory information, and also a little bit about your patient population, as far as size, what type of services that you provide, what type of IT vendors you use for the EHR system, and things of that like. And we try to use that to shape the demo and how we kind of the use cases that we show you. Then we also do a full-on demo where we can have someone from Care bring in and show you the platform. So I usually do an overview, kind of like how I did this presentation, and we can do those multiple times, kind of show different people at your about the purpose. And then one of the bigger pieces is the exchange trust agreement. This is the standard agreement that all participants of the EDCC program sign that basically goes over your data use agreement, your DAA, things of that like, make sure just to that agreement on the data sheet. Like I said, this is standard across all organizations. So we really don't accept a lot of red lines, things like that for this agreement. So that way we know everything, like, you know what other organizations. And then we go on through IT implementation, where actually someone from the Point Click Care team will be assigned to be your implementation lead. You'll do a kickoff meeting, go through things like getting that eligibility file set up and transferred over, and also basic user access. And so I did want to highlight this for those who might be participating in EDCC to some extent, but maybe not utilize these features. We usually don't go over these a ton in our normal kind of demos, but there are also ways to get scheduled reports. And so here's a couple of examples of what that might look like. In the platform, you can actually add patient population. So that's what these kind of cohorts or groupings look like. So if you have a specific a program where you have like 50 participants participating in, you can actually note that on your file, and that way you can receive reports specifically for those patients. And this is kind of an overview of what that report builder form looks like. It's basically what we get from you guys to help build some of those scheduled reports and kind of what the options might look like for them. And then next, just to highlight a couple success stories, we have from RBHA, who used the program for a while now. They're a CSP that's been using it think they were one of the first to start participating in the program. And they use it in a variety of different ways, but they use it for encounter notifications to re-engage clients they might not have been out or been out of touch with. Rappahannock Area Community Service Board has also been a great participant in the program. They've used the custom schedule reports for different things and some of their grant work as well for reporting sake. And then Family Insights as well uses access to CCD functionalities for medication duplication and coordinate better with. So with that, I'll give a quick second for any questions about that program, and we'll also leave. Yeah. So we'll receive inpatient like ADPP similar to what. Gotcha. Hopefully I've been standing close enough. Anyone else with questions at this point? If not,
Now you get to hear from me, not on a segue. Hi, everybody. So like I said, I'm Nicole Fawcett. I'm the Director of Operations at VHI. And I'm going to be giving you guys today an overview of a few of VHI's administrative data programs. So just to give you a little bit of background, Marcus showed that timeline of VHI kind of at the beginning of the presentation. And historically, as you could tell, VHI became the state designated HIE in 2019, but there's a long history beginning in 1993 before that. And we've always been a health data organization from the beginning. And so we have some of these more legacy administrative data programs, which of course, the biggest difference between those and the overview Marcus just gave is that it's not real-time data. But the benefit for that is, and we'll get into that later, how those data sources can be beneficial and might be able to be useful for you all in conjunction with some of that real-time notification information that you're getting from the EDCC and from HIE data sources in general. So Marcus kind of touched on this a little bit, but in the past, VHI is focused on, oh, well, we're going to collect and disseminate data, and that's what we do. So we're going to report data on our website. Once we are given legislative authority to collect this data, we're going to disseminate it to different stakeholders across the Commonwealth, and we still do that. I think, as Marcus mentioned, with our mission statement kind of changing, we are focusing a lot less, I should say, on reporting on our website and on our own internal analytics. And we're focusing a lot more on how do we empower others and kind of be that liaison for data that allows entities such as you all to be propped up in what you're doing with your data and your success stories and your use cases. So, I mean, we do, I just hit this and it did that. That's really fancy. Cool. Oh, was it just a coincidence? Okay. Anyway, fancy. I was like, wow, cool. So anyway, it's okay. I was ready to go to the next slide anyway. So I'm going to go over these 3 data sources on the screen today. Like I said, there are more. I just, we could talk about this for hours and I don't have hours to spend with you all on this. And also I wanted to try to sort of comb through what I thought would be the most applicable data sources or the most useful for you all specifically. So first, getting into the all payer claims database, which is by far the most nuanced and the most robust of all that I'm going to go over today. So we'll probably spend a majority of the time talking about the APCD. So Marcus asked the question, I know at the beginning, who's heard of it? APCDs are not unique to Virginia. There are multiple states across the country that administer APCDs. Some of them are voluntary, some of them are mandatory, some of them are housed by the state, some of them, like Virginia, since VHI is not a state agency, are not housed within the state. So there's a variety of there's a varied landscape in terms of APCDs across the United States. But essentially what the APCD is it's a repository or a database of paid medical and pharmacy claims that are submitted by payers. So payers are the data source for this data collection, and essentially they're submitting for us to repurpose the record that is prepared during their interactions in arbitration with providers. That's essentially what it is. And so in Virginia specifically, so it started out as voluntary in Virginia in 2013, and then it became mandatory for us in the 2019 General Assembly session. And so essentially any payer with a minimum number of, I believe, 1,000 Virginia resident covered lives is required to submit this information to the APCD. And so that spans commercial, Medicaid, and Medicare coverage. There are certain pockets that it's kind of nuanced. Like, for example, the legislation is not applicable for ERISA self-insured employers. So we don't get that data. We don't get data for federal employees. We don't get veteran data. So there are certain populations that are missing from that commercial bucket, but the Medicaid and Medicare are at 100%, and the commercial's hovering around half the commercially insured in the state. So I guess the name all payer claims data is a little misleading, but there's majority of people are in there. And as is mentioned on the slide, so in addition to the actual record of the claim that was either paid or denied or whatever, there's a corresponding enrollment record for all of those. And so you're seeing who's that patient, some of their demographics, how old are they, what zip code do they live in, stuff like that. The biggest value add here is that all of this is linked over time. So if I have Anthem over here, I get Anthem through my employer, cool. And then I leave that job and it's hard for me to find a job for a while. And now I qualify for Medicaid and I'm on Medicaid. And then I find a job and I hop off Medicaid and I hop back and now I'm with Aetna or whatever. You're going to be able to see, you're not going to know that it's Nicole Fawcett because it's de-identified, but you're going to be able to see, okay, patient 1, 2, 3, 4, 5 had Anthem, then they had Medicaid, then they were on Medicaid, then now they have Aetna. And so it's also applicable across settings of care. So it's not, if I'm in the inpatient setting versus if I go fill my prescription at CVS versus if I break my leg and now I'm in an ambulance and then I'm going here and then now I'm getting physical therapy over the next 3 months at a freestanding facility. Like all of that is linked across the board for the same patient. And so that's really the value add here is regardless of the setting of care, regardless of the patient's coverage, as long as they do have coverage, because it won't generate a claim if you don't have insurance. So all of that information is going to be linked over time longitudinally for the same patient. And then, of course, given that they are claims, there will be a cost or allowed amounts associated with those as well. So like I mentioned, these are the primary advantages of a data source like this, is that all of this is linked over time for the same patient. And so when you start to aggregate that up and kind of parse through all of that, you get this wide view of what does healthcare utilization just look like in Virginia, period. It can be very helpful for that. I know the Department of Health is a very high utilizer of this data, and I don't remember if I get into that on a future slide or not, but for population health, it can be very useful for those reasons. Assessing efficacy of certain public health initiatives, things like that. So because it's able to do all that stuff and you can kind of make it work for you, I think one thing that we always say at VHI is it's like the APCD is probably like not the best for anything, but the second best for like almost everything, right? So it's kind of like if there's no other data source that's out there that's available for you to be able to take this wide overview of whatever it is you're trying to look at, the APCD probably has something. But because there are all those pockets that are missing and there are some limitations with the data, especially for you all with 42 CFR and stuff like that, it's like probably never the best for anything. So therefore, it's just a really good data source that we use as like a temperature test for a lot of things. Researchers love the APCD because it's so much data. There are billions of records in there, and it really allows you to get into the nitty gritty and come to some of those conclusions. So back to the slide, common use cases, healthcare cost benchmarking. Like I said, of course, you're talking about claims, so there's going to be allowed amounts and paid amounts and things like that on there, and that can be helpful. We have a healthcare pricing benchmarking dashboard on our website. The APCD is also used for when the balance billing legislation went through in Virginia. The APCD is the data source that's used for that. The file that's posted on the SEC website that is now required to be used in arbitration when it gets to that stage. So it's helpful for the cost information. Analyzing prescription patterns I have on there. Like I said, you're getting prescription drug data in there. Rates of chronic illness, we talked about that wide overview. And then just assessing the prevalence of certain conditions or certain procedures and utilization rates in general. It's helpful for that. So here are just some examples. These aren't necessarily behavioral health specific, but just to kind of give you an idea of how the data has been used, particularly within the past recent few years. So maybe you can be thinking about, well, how does my organization fit into this? How can this information be useful for me? Marcus mentioned VCHI, or the Virginia Center for Health Innovation, earlier while he was speaking. We work very closely and collaboratively with them. They published the state's health value dashboard, like Marcus mentioned. And so they headed up an initiative called Smarter Care Virginia. 6 major health systems across the state were participants. And essentially what we did was we used data from the APCD to identify potentially low value and potentially high value services that were being offered by clinicians employed at those health systems. And so we use the APCD to essentially generate provider-specific reports to over 1,000 practices, and these reports were flowing down to those practices so that at each of these health systems they could have a very specific conversation with each provider, either to prop up those who were administering a lot of high-value care, or to kind of have a conversation with any of those who tended to be administering low-value care. And so the APCD was a large reason why that work was able to take place. I mentioned already that the APCD is used in arbitration between the providers and the plans as a result of the balance billing legislation that went through a few years back. And that's been valuable, of course. I mentioned that how much researchers love this data, and they really do, because of the volume and the breadth and the depth that's there. And so I would say a primary user of this data are those academic research institutions. And so over time, that's resulted in millions in grant funding and hundreds of reports that have been circulated. Some super granular, some basically the whole database if they have the money for it. So that's been really valuable as well. And then the governor's task force on primary care, there was this, I think VCHI also headed up this work. The APCD, as is mentioned on the slide, highlighted a discrepancy in primary care spending in Medicaid as part of work that VCHI was doing for that task force. And essentially that resulted in an increased payment of $80 million for those providers because the APCD was kind of able to back that notion. And so these are just some of the examples. Of course, I'm sure if any researcher was here, they'd be really excited to tell you about their specific work with the APCD. So moving on to the next data source, and again, I could talk about the APCD all day. When I was hired at VHI, that's what I was working on initially. So it's near and dear to my heart. We'll take it back a little bit further though to the annual licensure survey data. So VHI, when VHI started in 1993, the initial task VHI was given was to administer the patient level data system, which is the last thing I'm going to talk about. So I'll get to that in a few minutes. And very shortly after, a couple years after that, VHI was tasked with housing essentially an annual data collection from basically any organization or healthcare provider in Virginia who's subject to the CON process. So all hospitals, all ASCs, all nursing homes, CCRCs, and then any freestanding facility that administers COPN reviewable services is essentially who started reporting data to VHI. The data that they report includes all of their financials, which are then validated, and they have to back them by sending in their audited financial statements. And then they send in general utilization information like how many beds do you have? How many surgeries did you perform over the past year? How many CTs? How many MRIs? Mostly specific to services that are COPN reviewable, emergency department information, stuff like that. And so the annual licensure survey data is the result of that utilization information that comes in as part of that collection. We call it the EPICS collection. I don't think anybody outside of VHI calls it that. So I won't refer to it as that for that reason. So this information, like I mentioned, is submitted annually by those entity types that are listed. And essentially, it's interesting because those who are subject to the CON process are who's required to report this information. And this information immediately feeds back into that process because when facilities go to apply for CON or anything like that, this is the primary data source that's being looked at by the Office of Licensure and Certification to say, okay, is there actually a need for what the facility is requesting? So as a result, since they're required to submit this information, it can be useful and it's inexpensive, which is nice. So this data, as is mentioned on the slide, is useful for analyzing trends in terms of what is a facility's capacity and what is the actual utilization looking like. So just examples of how this data can kind of help or what it can be answered. It can be an ultimate source for how many psych beds are licensed in Virginia, what proportion of Virginia emergency department visits resulted in a psych admission. And again, like obviously with something like the EDCC, you're getting those notifications in real time, right? Like if you're participating in that and somebody on your patient roster is presenting in the ED, immediately you know. This data source is really beneficial in a different way in that it goes all the way back to like 1998 or something. You know what I mean? So if you really want to be able to assess the trends of how often is this happening? How has the rate changed across the state or in my region or in my district over time? That's the kind of thing that this data source is going to be able to tell you, as well as which Virginia hospitals self-report that they make available substance abuse or psych services in their emergency department, because as I'm sure you all know, not all of them do. Okay, and I mentioned the patient level data a couple of times, so we'll get into it. This is VHI's first baby right at the beginning. So like I mentioned, in 1993, VHI was tasked with administering this database, and that's why VHI came into existence to begin with. So other states have a hospital discharge database like this one. Virginia's is specifically only limited to inpatient. And if all of you could just cross your fingers for us, because we're really trying to get the legislation pushed through to also make it outpatient, because that would be fantastic. But for now it's inpatient, which is also still great. So every single discharge from a Virginia licensed hospital is in this database back to 1993. They're required to submit this data. They're required to submit this data at least 95% accuracy as well. And they're charged if it's less accurate than that. So this data has an interesting relationship with the APCD in that when plans and providers are going through that process of, okay, I presented to the provider and I have insurance and people need to pay people and then I'm going to get a bill later. This is the record from the hospital's perspective. The APCD is that record of data from the health plan's perspective. And so there's a lot of overlap in the data that's available in these two data sources. I mentioned some of the holes with the APCD being those populations that are missing, like it says all payer claims, but it's not really the whole state population. The benefit, and I talked about that being kind of like second best for some things. It's definitely second best for assessing inpatient care because this is the first best, right? So this is comprehensive. It's inpatient only, but it's comprehensive and you can feel confident that everything is in there. And then again, because of the nature of why that record was really generated in the first place and just the fact that we're repurposing it, it has the financial information on there as well. And so the use cases for this can be somewhat similar to the APCD. You don't have that linkage across setting of care since it's only inpatient, but since it's comprehensive, it can really help to just kind of take a wider overview of the state, of your region, of your district, in terms of observing patient characteristics and circumstances across the inpatient setting, specific to psych hospitals, specific to psych units, maybe specific to neither. It allows you to compare hospital or physician performance for specific types of care. And then it also allows you to analyze where patients are going within a particular region, where they're going for general care, where they're going for specialty care. You are able to see where the patient resides since there are patient demographics. So you can see, like, are patients traveling? Like, are they being admitted? Where are they being admitted from? Where they're being transferred to? Things like that. There's also been obviously interest in this TDO information for a while, and now that's incorporated actually as of the most recent year of data officially as a flag. So any patients who are admitted under a TDO are now, or any admissions that are a result of a TDO are now flagged in the data as well. So it's evolving over time as well to just be geared toward more specific use cases. And that is all I had. I know that's a lot of information. Like, we really could have delved much deeper into a lot of those sources, but I will turn it back over to you all for questions if there are any. Yes. Yeah. Yeah, that's a good question. So the question was for prescription data. Would there be a way to essentially re-identify whether or not one of your patients were prescribed an opioid, for example, especially if it's a patient with kind of an OUD history? Yes and no. So with the APCD specifically, because that's where the prescription data lives, there's a lot of red tape as payers and providers have competing interests. And so, like I mentioned, if I, Nicole Fawcett, am covered by Anthem and then I jump to Medicaid and then I jump to Aetna, or like I go here and I go there, fill my prescription, blah, blah, all that stuff, you can't see that it's me. You can see that it's, oh, patient 1, 2, 3, 4, 5. Now, I will say that there is long-term plans or hopes that this data would be able to then be linked up into the HIE because you all have that relationship with the patients, right? So I don't think that that use case is actively happening. And I think that's why it's more like more of a research centric repository now, because it's like they don't need to see that it was Nicole Fawcett, you know what I mean? But there is the goal for VHI long term is to kind of dodge all the political stuff that we need to be able to have you do exactly that. Yeah. Yeah. Yes. Yeah, that's a good question. So the question was, is there any intention or plan or process in place to layer all of these data sources that have been mentioned today, including the data from the EDCC? Kind of same answer, yes and no. So the red tape with the APCD is the biggest barrier in doing that because essentially, I believe the bylaws for the APCD. So Marcus mentioned like there's a advisory committee that oversees the APCD and they are stewarding the legislation for that program and all that stuff. And it's multi-stakeholder. There are plans that sit on it, providers, Department of Health, you know, the whole thing. And at the moment, it is not permissible to link the APCD to a data source that can re-identify the patient. So that is the biggest barrier and the biggest kind of hole in terms of a need that the APCD could fill that it's not able to fill. Now, I will say that in terms of the inpatient and the APCD, yes, we're actively working on that linkage. The APCD, as I mentioned, you know, you wouldn't be able to know that it's me, but you would be able to know, oh, that's patient 1, 2, 3, 4, 5, right? And so that is a specific hashing mechanism of like social security number, essentially. So what VHI is actively working on is using that same hashing algorithm and applying it to the inpatient database so that those two can be linked on patient. And that'll also give us a really good idea of what is the volume that we're actually missing from that commercial population in the APCD. So we'll get there. More for you guys to cross your fingers about. Okay. Yes, we will. Thank you all so much. Yes, interrupt us while we eat.
All right, so just wanted to synthesize a couple of things real quick for us. We've heard about how we're leveraging data warehousing, right, to consolidate and use information internally from disparate data sources within an agency to then make better use of it. So, you know, it's a common problem that we have. You know, we think here at Western Tidewater about, man, how great would it be if our general ledger actually talked to our patient data, actually talked to our timekeeping system, and all the stuff that we could do off of that. I'm not as advanced as Fairfax is yet, but we're just going to steal all of Jen's technology and bring it down here. We'll sign an agreement with her. And then we hear about VHI and all of the good work that's done to consolidate data on the Commonwealth level, right? So to think about that I can have an individual walk into OBC Hospital here in Suffolk, and I can know how long that they were in the emergency department last night just by logging in and seeing that. And my PACT team can see that information and go out and respond to that patient today because they had a hospital ED visit. Those are the kinds of things that are starting to become available for all of us, and the things that we need to kind of keep an eye on. And it's why going from this diagram, which, the enemy of progress is complication, right? So the more that you simplify it, the less lines and things that happen, and the easier it is for a user to access and understand it, the better off we're going to be. That's kind of where we're trying to pull all these different things together today. Really timely because as Fairfax is working on their data warehouse, DBHDS has got an RFP underway, looking at data warehouse applications and those strategies. VHI, we've talked a lot about how EDCC has been helpful to us and what can we use in our data exchange that would be similar information as the Commonwealth moves down that road. There's a lot of, there was some intention in what we did to put this together. So I'm going to take this as an opportunity just to thank the work group that compiled the agenda and made all of this happen today, because it wasn't me. I would be remiss if I didn't call out Brandy first. So she's hid back in the corner today, very unlike her. But I think she's trying to be behaved for at least 30 seconds today. So Brandy's my DMC co-chair, the brains behind everything that we pretty much do. So Brandy was a huge part in organizing everything. We also had on our committee, Tracy Bricky, Jenna Loy, Nicole Lewis, Michelle Caston, Charles Burwell, Shay Neal Jones, and Craig Camage. They helped us put together kind of the package and think about what we were going to do here. So I'm very thankful for all of them. That's the smart folks that helped us. And then I have a group of people here at Western Tidewater that always prop me up. So I've got David, who's handled all of our IT solutions and made sure that we actually had things that worked in here today. Mitzi, who is our EHR admin, but she has helped us to get all of the kind of finer details organized. Shannon, who had to step away for something, but she'll be back in a little bit. And Kanisha and Erica, that you might have seen as you checked in today. So I'm thankful for them. They did all of the hard work, and I just got to come up here and talk and try to look as pretty as I could. So big thank you to all of them. And I'd like to ask you guys to go ahead and take about a 10-minute break, get back in here by 10:15. We'll start our next session at that point in time. Feel free to stretch your legs, walk around, check the thing out if you need to. Guided tours will be offered. He loves it when people come up and chat with him and want to do a guided tour. So thanks, y'all. All right, everybody. So thanks for taking a couple minutes to network and chat. We're going to go ahead and get rolling again so we stay on time and don't take away all of Chris's time to speak with us today. So Chris Burrows is here with us from the Office of Data Governance and Analytics. And she's going to talk to us a little bit about this and reveal all the hidden sources of wealth of information and wisdom that live in our state. So Chris, go ahead and take it away.
Well, thank you very much. So a little bit about me. My title is Director of Data Protection and Governance for the Office of Data Governance and Analytics, which is part of the Secretary of Administration branch of Commonwealth of Virginia. We're a relatively new agency. Prior to this, I was Chief Technology Officer for a global financial services firm. But then I saw this ad for this awesome job to basically take all these data elements that are in silos and put them together. I said, well, that sounds like an exciting challenge. So this is my first public sector job. So happy to be here. So we'll talk a little bit about what we do. And I'm sure all of you guys have data, right? Well, I said the world is one big data problem. It's a wonderful quote. I have a better quote, actually, which is, without data, you're just another person with an opinion. Ever heard that one? That's by Deming. Very famous engineer. He does Deming, a lot of process improvement. But yeah, I kind of like that quote better. Probably not as politically correct as this one, right? So let's talk about what the Office of Data Governance and Analytics does. We're here to help you, first of all. We facilitate data sharing among not just the state agencies, but localities, private sector. Our job is to bring data together and help you in any way we can, whether it is data governance, visualizations, and I'm going to talk about some of the services that we offer in our agency. So first, I'm going to start off with a use case. I think it's the easiest way to understand data is through dashboards and reporting and use cases. So that's where we'll start. So one of the big projects we worked on was a governor's initiative. He wanted to reduce violent crime across the Commonwealth. So he came to us and said, in a partnership with Virginia State Police and the local police departments, can you help me have a crime dashboard? So he wanted to see where those high crime areas had violent crime. And I'll tell you, we did not reduce crime ourselves by creating a dashboard. We were just a mere participant in this. So what we did is we made a dashboard, and I'll show you the example of it, showing the incidence of violent crime per region. So therefore, the people who were trying to solve this problem could actually see, one, how many crimes were there with a weapon, how many assaults, they had all the data, and then they could plan around that and figure out where to deploy resources. And we gave them all that information. They followed the trends, and that way they could move resources around in the state and in those localities. And the governor did a press release about this, and the results were pretty amazing. Okay, so as part of this initiative, they increased felony arrests, they seized fentanyl, they were very focused on this. So again, data didn't solve this problem, but data helped solve the problem. And I'm sure you have big problems like this. Some other things that we are doing at the Office of Data Governance and Analytics is we have dashboards for the Department of Veterans Services. So we are trying to find out, where are the veterans located, and do they have VA hospitals near them? What resources are available? So we're taking data from disparate sources and putting it better together to better serve the citizens of the Commonwealth. We're working with the Department of Forensic Services and said, how quickly can we process crime information or the evidence? And they're trying to improve that. And one thing I think that's going to hit close to home is we also work with the Chief Transformation Office to improve the DMV wait times. So you like that? Yes. See, I thought that was my big one at the end. Start with violent crime, and then how long does it take to get your driver's license renewed? So we took all that call center data, right? We said, not just what they did is they looked at which locations are actually, which regions had the longest wait times, then which locations had the longest wait times, and then which customer service agent had the longest wait time. So they could say, hey, Ethel, you need to pick up the pace a little, right? But that was all facilitated through the use of data. So this, I think, is the big thing that everybody sees about what the Office of Data Governance does. We do these visualizations and dashboards and do trend analysis, but there's a lot more going on in our agency. Sorry, I forgot about this slide. So this is a copy of the dashboard. I did redact all the information so you can't tell where the crime is. So we do these visualizations. We're here to help you. So this is a service that we provide. So if you have data and you need some way to analyze it, we use Power BI. We ingest the data sources, and I'll talk more about the technical side of this a little later on. And we pull it together, and we can publish these dashboards to your agency or to the general public. Okay. So what other services do we offer? So we will scan your both structured and unstructured data. So if you're not from an IT background, structured data is databases, things in tables. Unstructured data is Excel, Word, PDFs, and such. So, and when I say we scan it, what are we scanning for? We're looking for PII. Okay. So one agency that I worked with, we used our tool. It's called Microsoft Purview. We scanned the tables in to find out what tables and columns they had. And then we looked for sensitive information. And she said, we don't have sensitive information. We got rid of social security numbers ages ago. Well, we did the scan, and guess what? In her Dev and Test databases, that's where she still has some social security numbers. Okay. So from that, you can do a number of things, right? You can secure it, or you can get rid of it. I recommend getting rid of it. That's a whole lot easier from an IT perspective. So, you know, you don't want to get surprised if there's ever a data breach that you didn't know that you had sensitive data in a particular source. Also, as part of that structured data scanning, we can help you with metadata management. So you can actually document what those columns or fields mean in your data. And I'll talk more about that in a moment. On the unstructured data, same kind of thing. I'll tell you, a previous company I worked for, we had to be PCI compliant, which was for credit cards. And everybody's like, oh, the system of record, we're good. That's where all the credit card information is. And I did a scan there, and I had a trial version. It's great. Clicked on scan now, figured I'd find a couple instances where there's an Excel file with some credit card numbers. It found 11,000 incidents of credit card numbers across the organization because people would take it out of the system of record, put it in Excel, right? So that's a huge risk. So what we want to do is, whether you have HIPAA, FERPA, CGIS, whatever the regulations we have across the Commonwealth, we want to make sure both your structured data and your unstructured data is in compliance and that there's no surprises there. Okay. We also have a data catalog. Talk more about that also with the Open Data Portal. But what we're doing is creating a Commonwealth-wide data catalog. What does that mean? It means we're working on a list of all the data sources, data elements that will be available for you to query. I just talked to a gentleman at Virginia ABC, and he came to me looking for alcohol-related data, and I was like, well, I thought you had all that. But what he was actually looking for was not like what they're selling at the ABC stores and all. He wanted to find information like, similar to the veterans, where are their Alcoholics Anonymous meetings? Well, we actually had that already on our Open Data Portal. So he can combine, here's where the ABC stores are, and here's where support groups and such are. And he puts that together to make sure that we're not creating a problem with alcohol. So that's kind of how you can use a data catalog. You look for data, basically I type in the word alcohol and see what comes up and say, hey, I know where we can get that for you, or we already have it. Let me contact the data owner. Now, anything that you put in the data catalog, it doesn't mean it goes in some big bucket of data and anybody who wants it can get to it. Okay. So when we either scan your data or you contribute data, the data owner is always the one who decides who has permissions to access it. So in this case, where the Alcohol Anonymous meetings was public data already, it was on the Open Data Portal, nothing was needed there. But if it's anything that needs to be secured, then what we do, we have a process to reach out to the data owner and say, this agency would like information that you have. Can they get access to it? And then we put them together. By the way, I should have mentioned, if you have questions throughout, you're welcome. You don't have to wait till the end. I like to talk. I like to answer questions. We can make this very interactive. Okay. So what else do we do? Training. Okay. So one of the first things I was charged with when I joined the agency in December was creating a data governance training program. The Commonwealth is recognizing the importance of data, but everybody's been focused on putting things in, right? But how about getting things out? How do we become good stewards of all the Commonwealth's information? So a couple training classes we created. There's a data owner class now. And hopefully you know that the data owners are the ones who are accountable for the data, not the guy in IT. I said that for you. All right. The IT folks are the data custodian. We have training for them, and I make it very clear what the role of the data owner is, which is they're the ones who have to make sure that they're in compliance with regulations. They need to figure out the classification, the security. The data owner creates all the rules, and they're usually an agency head, a senior level management of an organization. So we have that online training class for folks. Then I also have the data custodian training, which is usually the DBAs or system admin, like here's your responsibility when you have this sensitive data. Okay? I'm also working on data quality training. So instead of worrying about the data stewards who have to clean up all the bad data, I'm trying to get in touch with the folks at the front line and say, could you please type it in correctly? Okay. So you're with me, right? So, I mean, we have found things as we're seeing all the different data sets, right? One of the things we had an intern come and he said, I just saw there's a 2-year-old who has a DUI. What? No, that's a data quality problem. Okay, right. So, but people make decisions then on bad information like that, right? There is not a rash of toddlers driving around and drinking. Okay, that's not true. And it is a real example we have, but sometimes, there may be more nuanced conclusions that people draw from bad data. So it's very important to clean it up. And again, it's a lot of work to clean up on the back end. So I want to help the front end people not type in 1101 as the date, right? You're nodding your head because you've seen the bad data, right? all the time, okay? So that's going to be released before the end of the year, that data quality training. That one's going to be fun. Data owner, data custodian, a little boring. It's all role-based training. And it is required by Sec 527. So if you're a state agency, your folks have to take that class. And then as I talked on the case study up at the beginning of the presentation, we do data visualizations. We have Power BI specialists that work for us. So kind of you give us your data or you give us access to your data. You don't have to actually put it in our systems, but then we will create those dashboards for you. Some other things we do is metadata curation. So if you're just getting started with data governance, or even if you've been doing it for a while, like metadata curation, all the data governance, data lineage, things like that, it's hard. We do have specialists that know how to do this, that can help you with your curation. So please contact us. We are entirely in Azure in the cloud. So if you want just a place to store large volumes of data, we can facilitate that. And then we will facilitate data sharing. So let's talk about data sharing, because that makes everybody nervous, right? I want to keep my information close to the vest. I've got regulations. I don't know if I can trust you. I don't want to be on the front page of the newspaper. So a lot of times, we know the benefits of data sharing, but what about those challenges? So we do get resistance to giving away our data. People have concerns about getting PII released. There's data breaches in the news every day. Some organizations may have infrastructure limitations, so it could just be storage, but it could be you've got all your data locked in PDFs and you need to get it out. We can help you there. Also, people don't know how to even get started with data sharing and governance. So we have solutions for that. And then lack of funding, right? It's always lack of funding. So that's why ODJ does have some services. Some we provide for free. Other ones, we do have small charges. We're typically less expensive than if you go out on the open market for these issues. And how do we do all this? Well, it's through the Commonwealth Data Trust. So I was listening to your presentation, and I think, as we're trying to share data between agencies, ODGA has something called a Commonwealth Data Trust that you can all be members of. It's not just for state agencies, it's localities, private sector, and such. So before we started this Commonwealth Data Trust, this is kind of a model of how things happen, right? One agency talks to another agency and they have an MOU, right? Then another agency has another MOU here and another MOU, right? It's like kind of spaghetti. Everybody's interconnected and trying to figure out how to get these contractual agreements in place so they can share data and have the protections they need from a data security and confidentiality perspective. So what we've done here is the Office of Data Governance and Analytics acts as a broker. So you sign one agreement with the Office of Data Governance and Analytics, and then you're either a member, means you're contributing data, or a user saying you're trying to use our data, okay? And again, all of the controls are with the data owner. So if any of the agencies here want to provide us data or even add your data to the data catalog, before anybody can get to it, we reach out to you and have a workflow for that. Okay. And we've done this in a number of cases. So there was two agencies that wanted to work together. They had some federal reporting requirements. And so what they did is each agency signed a contract with us. It's very easy to do. We can get them done in 3 days. And then they were able to combine the data and automate those monthly reports that they were trying to get accomplished to meet their regulations. Okay. Well, that's really hard to read, at least for me. So what I have here is a chart. I can give you these slides. I've bolded those agencies that are already a member of the Commonwealth Data Trust. So you can see there's all the agencies, the executive agencies on that slide and that table. Okay. And then the ones that are in bold, we already have an agreement with, which means it's going to be very easy for you to work with them to exchange data. On the right-hand side, there's some non-executive agencies. You see at the bottom, there's a lot of police departments. Well, that was that case study that we worked on. We have a lot of crime data, have a lot of healthcare data. VDH and DMAS are huge contributors to the data trust for us. So if you're interested in working with any of these folks, please let me know. So what are the benefits to the Commonwealth Data Trust? One, it helps you financially, less work to get all those contracts in place, right? there's also the services. If you sign up to be a member of the Commonwealth Data Trust, you get some free services. And I'm going to talk about those in a minute. And then you also, by not having all these connections between all the agencies and kind of, when you get geeky, opening up all these network ports and firewalls and things, if you just kind of work with one hub, you have less exposure, less attack surface for data breaches. So one of the benefits we have is a Dataversity scholarship. So if for executive branch agencies, we are trying to, again, support everyone in their journey for data governance. So we offer a free scholarship, one person per executive agency, to get data stewardship or data governance training. It's about a $1,900 value. It actually gets you certified for DMBOK and CDMP, if that's something you want to do for your career. There's also classes on data stewardship, data quality, data lineage, AI, ML, I mean, reporting, anything data related. There's over 400 classes that you get unlimited access to when you sign up for the Commonwealth Data Trust as an executive agency. And overall, we're just trying to promote data literacy across the Commonwealth. I've got some other initiatives planned for next year to do some real-time data literacy training for employees, as well as even maybe citizens, if I get enough money. And what I mean by data literacy, it's not data stewardship. It is, when you say the word per capita, what does that mean? Okay, people don't always know. You know, really talking about how do you interpret the data that you're seeing? And so basically maturing those data literacy skills. So when somebody looks at a report, they can interpret it properly. So what do we have today that'll get you access to data? I heard you guys have some great data sources. Maybe we can get together because we do have the Virginia Open Data Portal. So if you go to data.virginia.gov, that is all public data. So when I was talking to you about the gentleman from the ABC board, if you want to find the Alcoholics Anonymous locations, that's on the Open Data Portal. There's information. We have some federal information like U.S. Census Bureau. Information is already curated and out there. There's information a lot from VDH related to COVID. I think when I talked to the gentleman there who's responsible for data governance, he got tired of the FOIA request. Everybody was asking about COVID this, COVID that. So now he just puts it on the Open Data Portal and says, kind of get it yourself. So that way they don't have to prepare it. So he puts it up on the portal, and then all the reporters and such have access to that information. So this is what it looks like if you go to the home screen. You just put your search term in. So if you want to search for bike trails in Virginia, whatever, you just type in bike and data sets will come up. You want to type COVID, you want to do education, it is all there. A little hard to see this, but this is when you search for something, you basically get a list of data sets, when they were last updated, a description of the data set on the left-hand side. You can query by category if you want to narrow COVID down to education. So you're looking for COVID in schools, right? You can filter on that. There's a number of key tags, and if you want different, I'm trying to think, classifications of the data, that's all up here. So, and basically then you just click on whatever you see there, like that first one says COVID, click on that and it says view data. You can just, and then you download the data, or you can create visualizations within the portal itself. Now the Open Data Portal is for public data sharing. So if you want to build a dashboard, give it to the general public, you put it on the Open Data Portal. But sometimes we have confidential information. We still want to share, but we don't want it available to the general public. So we have another platform called IDEA. We have used it for the FACT project, which was for the opioid epidemic, for COVID, and then for human trafficking. So those were internal to the Commonwealth of Virginia projects. And so we combine that data together in this IDEA portal. And then we can set permissions that says only these people can access this data. So it facilitates data sharing, but you have the proper controls on it. And then finally, we do projects where the data is not on either of these portals, but it's in the ODGA technical environment in Azure. So we can take data from numerous sources. Sometimes we get them from databases, sometimes we get them from Excel files and they're FTP'd in. They can come, any way you want, bring them in. We will ingest that data into our systems. We have an Azure data warehouse based on SQL as well as Synapse. So we bring it in. And then we figure out what to do with it. Is it just there to be shared? So is it a pass through? Are we going to create reports, visualizations, or predictive analytics? So we do have a data scientist on staff who can actually do machine learning and build models for you based on the data that you have. Yeah, stop me for questions. And then boards and councils. So we don't just do this all in a vacuum. We have numerous governance bodies that work with us to both provide advice and oversight with everything we're doing at ODGA. So one of them is the Executive Data Board. So that is executive members of the various agencies we work with. They meet as a board to basically figure out what the Commonwealth wants to achieve and provide feedback to ODGA on where we should focus our efforts. So they are telling us about their data projects. And then they put people on the Data Governance Council, which the Data Governance Council is more focused on policies, procedures, what does our business glossary look like, what are our standards for metadata, things like that. So the first one is about data projects and leveraging data for different uses. The other one is the Data Governance Council. And then we also have the Virginia Data Advisory Commission. So those are senators, delegates, private sector individuals that come together and really look at the future, right? Where are we going in the Commonwealth with data? So those are our three main governing bodies. It's getting very exciting right now with AI. When you start thinking about where data is going to fit in there, like should we use Commonwealth data to train machine learning models? I don't know if you saw, it was just released yesterday, or night before last, the governor's position on AI. So there's going to be a lot of work being done to figure out what do we do about, keeping data secure, but then leveraging it to benefit the citizens of the Commonwealth. And should we, as I said, train models, use AI chatbots? What's going on there? And well, you can't do any of these AI things if you have bad data, right? So we have to really, as a Commonwealth, get our data in order so that we can do some of these future things like those chatbots. You don't want it spitting out the wrong information, right? So I will leave you with this. I hope that all of you guys are networking and talking to one another and making friends, but also talking about what data you have and what maybe you can get from some of the other folks in this room. I think there's a lot of potential in data. That's why I joined the organization. I think we can really drive change in the Commonwealth and better serve the citizens of the Commonwealth if we leverage the data that we have in our silos. If you heard anything in this presentation that you're interested in, you can click on that QR code or send an email to this email address. If you want us to scan your data, create Power BI reports, just share amongst the different agencies, please let us know. We are here to help. And we really do want to unleash the potential of all the data sources that we have in the Commonwealth. That's it. Questions? No. I have a comedy act that comes later. Yes. Well, I would love to talk to you about that because we've been trying to get the data owner, data steward from your group after Mahesh left, because that's when I send the invitation to join us at Dataversity. So it is one scholarship per agency at this point. So 400, but yes, part of that scholarship. But the data owner and the data custodian training is available to everyone, not just executive agencies. Tell your friends that that's public. We built it in-house. It is available in the Commonwealth LMS, COVLC. I also have what they call the SCORM files. So basically the course content that you can upload to whatever learning management system you have. If you're using the KnowBe4 system that Vita has, you can upload it there. Or if you have your own, just upload it. We're giving that away for free. I talked to the city of Fredericksburg at another conference and said, you can have it. No need to create it yourself. And if you have suggestions, I can improve it because we built it. Yes, it is. Coming soon. I'm working on that. By the end of the year. That's my personal goal, yes. And it will be fun because we're going to do kind of a Jeopardy thing and say, can you spot the data quality issue? And so, yeah, I like to have fun at work. Owner and custodian, data quality, that one is going to be, you're going to tell your friends to take that class. I hope. Any other questions? Yes. Yes, yes. So we have them also in the data catalog. We have, here's the data set, let's call it COVID. And you can see it came from VDH. We've got who the data owner, the data steward is, a description of what's in there. You can actually see the columns and then the metadata, if there's sensitive information, and that's all in there. Any other questions? Y'all may. You just want to go to your next session. See, I ended up early. Come on, ask me questions. No, that's it. All right. I am done early, so thank you everyone for your attention. I hope to hear from you. Click on our QR code. Bring it up.
Chris, thank you so much.
Oh, my pleasure.
Appreciate it. Excellent job. All right, so I'm sure that we'll have folks reaching out some classes and things like that. Really appreciate that presentation. We're going to go ahead and get some things queued up. We're going to transition from some more of our technical stuff to the most technical person here. It's Brett. No, I'm just kidding. Brett's from the National Council. He's going to be talking to us a little bit about CCBHC and interoperability together. He made me promise to tell you all that he's not going to be designing you any data warehouses. He's not going to be coming up with schematics for how you exchange information securely, any of those kind of things, but he is going to give us some information. I told him there are some clinical folks in this room that will definitely appreciate his stuff, and all the rest of us will just doze off while he presents. And he is the only thing between us and lunch, so he's really thankful to Chris for ending a little bit early so he can start a couple minutes early and not really feel like he's keeping you from getting to eat. So are you good to go? Okay, great. Amazing. Wow. And you said you weren't the IT.
You know, hey, good afternoon, everybody, or good morning. I know the last before you have lunch. As was shared, I am not a data or technology expert. I'm a social worker. My mom jokes that I have a master's in feelings. So I'm from the National Council for Mental Wellbeing. You may know it as the National Council for Behavioral Health. We changed our name about 1.5 years, 2 years ago, because public information showed that when people think about behavioral health, they think about the manifestation of symptoms when an individual has untreated mental health or substance use challenges. So we reshifted our name to really focus on what that dream is, right? So having that mental well-being. So if you are familiar with National Council, we are the same organization. Also, you know, NatCon, large conference. So today I'll be talking about certified community behavioral health clinics. And I'm curious, who's heard of CCBHCs before? Oh, so the majority of the room here. That's great. So because sometimes we go into these conversations and folks are as unfamiliar. So I'll go into a little bit more depth with what the model is then. You know, as I mentioned, I'm a social worker. My job at National Council is I work with states. So I help states to understand the model and then work to help them tailor it in ways that can be specific for their needs. Virginia is a state that's moving forward with CCBHC, so I can give you a bit more information and context so that can help you all in kind of making those decisions and helping them move those things forward. So when we talk about CCBHC, we talk about it as this kind of three-legged stool. One is integrated care. And so we talk about integrated care often as like integrating mental health and substance use or integrating behavioral health and primary care. I talk about it as integrating mental health and substance use into the community. Because with the CCBHC model, you're able to receive Medicaid reimbursement when you're delivering services in somebody's home, when you're in a school, if you're in a courtroom. you're able to receive that Medicaid reimbursement. So you're opening that door where somebody is and not requiring them to go to your open door within the clinic. It's cost-related reimbursement. So if you're familiar with prospective payment systems that FQHCs have, it is similar to that, but some differences. One is that, again, reimbursement outside those four walls. You also are looking forward and seeing what is it going to cost in order for us to achieve equitable access to these services. And also you're able to include costs of other provider types, other technologies and things like that that are often not allowed within other types of payment systems. And then you have a quality care metric. So CCBHC is a model that requires every provider to have the baseline of quality metrics that they're capturing. States can add on additional ones, clinics can take it upon themselves to add additional ones as well. And all of that kind of validates both the costs that are coming into the clinic from Medicaid, as well as those services and partnerships for those integrated services. When you are going through the CCBHC model, so on the left-hand side of the slide here, you'll see this is a list of all the 6 criteria: staffing, availability, accessibility, et cetera. So within the care coordination piece, there are HIT requirements. So your clinic has to level up what it's doing when it's converting to a CCBHC. So it has to have enhanced EHRs. You have to be able to kind of track those population health needs. You have to be able to focus on your quality metrics. You also have the opportunity in the scope of services criteria to be able to craft other partnerships. So I'll talk about that here in a minute, but this is a key way where if you are, as a clinic, working with other partners, and let's say that that organization has a fee-for-service, you're providing a service that has a particular fee-for-service rate, but you're describing in that partnership, well, it actually costs more than what that reimbursement rate is. So you create a revenue stream for them based off what it actually costs, not just based off what that reimbursement rate is. When we're looking at the right-hand side of the screen, these are kind of some of the key takeaways when we think about the model. So somebody had mentioned, around accessibility. So you have to serve everybody regardless of ability to pay. Anybody who has a mental health or substance use diagnosis. Clinics can create a sliding scale fee for folks who are not Medicaid enrolled. Maybe they have commercial pay, maybe they have private pay, to be able to meet those needs. You also have to be able to, if somebody raises their hand for care, they have to be able to get in for services within 10 business days. If they are in a moment of crisis or have a more immediate need, the timeline is much faster. You have to be able to provide 24/7 mobile crisis response, also an array of other crisis services, and you have to have partnerships with law enforcement, with schools, with your FQHCs, with your hospital system. So there's just a kind of across the board, a making of an inner working web to ensure that wherever somebody is, wherever they're receiving services, that clinic is connected to it. And that's relevant to today's conversation, those data systems are connected so that the CCBHC can be a one-stop shop for information for that catchment area. So everything related to outpatient mental health and substance use care, and where appropriate, where allowable, by your state or by that clinic, kind of working to understand too what relates to those ED visits, those inpatient visits, hospital stays. So talking about DCOs, and I want to mention this because this is something that a lot of states are really focusing on. So the DCO is called a designated collaborating organization, and it's something unique to CCBHCs. So again, if I am a CSB, but there is an opioid treatment provider, so a methadone provider that is, within my region, or maybe it's county over, or maybe it's in another area, but there's a number of clients that I'm working with who have OUD who may benefit from a stronger or more robust methadone provider. You can create a revenue stream to that provider that you then build into your rate that helps them to better care coordinate care and integrate services and share data and work in partnership with your law enforcement partners, their law enforcement partners, as appropriate, as relevant, looking and sharing. So that it creates a mechanism where it's not just kind of forced care coordination, because sometimes, and I was also previously working for a state, states can mandate something or require something and not have the monies to back it. The clinic is able to identify what that actually will cost and build that into its rate for those different partnerships. I've also seen DCOs work really innovatively around schools. So if there's a school counselor, oftentimes school counselors don't have the same clinical oversight. They don't have the same kinds of data sharing or opportunities there, and they don't work after hours or over the summer. But the CCBHC can build in the costs of having that school counselor on their payroll as well to coordinate care, coordinate services, work with them over the summer. So there's a lot of innovative ways, and states are thinking about this in ways that can be tailored to a community, but also statewide. So I want to make sure to mention that because if you have ideas at the local level, as your state's kind of crafting what potentially could be those criteria, what it would want to put into an application to be a demonstration state, these are things that could be relevant to approach them with. So you all said you kind of heard of CCBHC, so I'll kind of walk through this a little bit historically, just for the folks who maybe haven't heard of it. The model was launched in 2014. This was done by the Protecting Access to Medicare Act. When it was established, it actually didn't launch until about 3 years later. So when it launched, there was 8 states that were identified as demonstration states, and the demonstration focuses on a Medicaid rate. So this is a Medicaid rate to clinics that is a bundled payment rate encompassing of whatever it is going to cost to deliver equitable access to care. There was such interest, so 23 states were interested, including Virginia, that Congress later identified site-specific grants. And so there are 3 grants within Virginia. I looked yesterday; they announced updated grants. No Virginia providers received that grant. But it's $4 million for a 4-year period that helps the clinic to kind of level up its services to meet those needs. Within that, there's also a percentage of funds that can help to ensure that clinics can add new technologies, add new services, and also add new staff to manage that, so that social workers like myself are not having to work within databases and be able to actually provide clinical care to the top of their license. Kind of cutting to the chase, last year, Congress expanded this model to be able to be not just in those kind of 10 states, those eight original states, but actually be nationwide. So in about 6 months or so, there's just south of 20 states that are going to be applying. 15 states got grants to apply, but there's additional eligible states, including Virginia. So you could see this model within the next year launching here and being able to provide those supports and resources to your state. Here's again a map kind of nationwide. States that are blue or green are ones that are eligible for to apply for the demonstration. States that are in yellow or have a yellow check mark are states that have passed legislation to establish the CCBHC model. Ones that are in orange are those original demonstration states. So if you were to count everything, you would see that just over half of the country has established or is establishing the CCBHC model. And what's really important here is that, and I'll just give an example here with Kansas in the middle of the country. Kansas was the first state to pass legislation to establish the model. And it did so because they lost all of their talent to the neighboring states of Missouri and Oklahoma. Those clinics were able to hire staff, both clinical and non-clinical, with increased salaries, with advanced benefits, with flexible work time, again, pre-pandemic. So all of a sudden there was this brain drain that left Kansas because we're in a workforce crisis that moved to those other states where they could still provide services to folks who were Medicaid enrolled, still work with that population that they wanted, but were able to receive a salary, benefits, and kind of work-life balance that reflected really what they needed for their career. So the state reacted and was able to do a lot of really innovative things as it's establishing and building the model. But I say that because Virginia is seated right between North Carolina and West Virginia, two states who have been doing really innovative, thoughtful things when we think about CCBHC, and should they be selected, they will launch that model about. So just thinking from a competitive standpoint, where and how states are moving forward, what you'll want to be able to do. So states can establish the model via the demonstration, which is this orange line, and I lined that with the orange color of the map from the previous slide. Or they can do it via a waiver or state plan amendment. So these are all like Medicaid kind of jargon that folks who are maybe a Medicaid nerd like me get excited about. But when it comes to state financing, so there's a delta here between what the Virginia Medicaid rate is and what the demonstration rate would be. So that's just south of 15 percentage points. So if you calculated that statewide, it'd be about $40 million saved per year if the state were able to get into the demonstration. So that's a lot of money that could be reinvested into technologies, reinvested into clinical care, into trainings, into establishing more and better resources. So we've seen how other states like Missouri and others have thought about doing that. So wanting to just to kind of make that flag. So as your state's moving forward, ways in which you guys can help to champion that would be very helpful. So I want to get into the clinical data, and I've talked a little bit about some of the workforce pieces. So I'll just kind of give some more concrete information on that. But when it comes to expanding access to services, so on average, we see about a 23% increase in access to care for any clinic that either receives the grant or receives that Medicaid reimbursement rate. And when it comes to staff, we see that on average, we see about 27 new positions hired in each CCBHC. So not just posted, but actually 27 new positions. And for this audience, this is exciting because the second most hired position in those clinics are data analysts. So it's folks who say, if they already have one or two folks who do data, we say, and I just can't do what you need me to do. They will then hire on other folks. And what's great about that is, one, as I mentioned before, it alleviates the burden on social workers like me who don't know how to use a USB port, but also make sure that it provides that kind of work-life balance for other folks as they're working to kind of craft that partnership and share those data. You can also do partnerships with other organizations to alleviate that burden, as I mentioned, those TCO partnerships, or even MOUs or LOAs that kind of can have also a financial stream to it. So it really does help to strengthen quality of life, retention, hiring, recruiting. And you see it when you have that Medicaid reimbursement, both increase in access and also that staffing part are much higher than you would be with just a clinic. And I mentioned the grant because the first presenters kind of talked about how their work that they were able to do was, in some parts kind of due to a grant that they had received. And that's really stressful on any employee to make sure that you've got a good grant writer on staff who's going to keep that money coming in, that's going to make sure that you can kind of renew that, you can have that through. So this helps to alleviate that burden because you can include all the costs for all your technologies into that Medicaid rate. So it is sustainable for as long as your state is a state and receives Medicaid funds. So that's something that's pretty important. So the next two slides, I'm going to show you kind of some comparable data from one clinic that's a rural. So this clinic is just south of the Canadian border in Minnesota. They established the model in 2017. So did the one I'll show next. So you can see that when they, from 5 years into establishing CCBHC from 2017 to 2022, they almost doubled the number of clients that they served. They were able to increase their salaries for staff, including staff who are those subject matter experts as peers, so people with that lived or living experience, reduced time for comp eval, and then more than doubled their bottom line revenue. So this is a huge opportunity. This and the two clinics have also leaned heavily into technology, into those data partners, in order to make sure that they can share those data with their state and be able to be reflective and share what's appropriate for themselves so they can improve on their own. The next clinic is a bit of a behemoth. So this is a clinic just in suburban Missouri, Gorell Clinic, part of a larger entity called Brightly. So they went from having about 1,500 employees to just south of 3,000 within that 5-year period with providers. So people who I would actually describe them as clinical staff. They had about 150, and that's jumped up all the way to 425, again, within that 5-year period. And their revenue went from just south of 100, about 75 million to 200 million within that. So again, that revenue, it's not profit, right? It's revenue that they are able to build in and reflect on what's actually the cost of care. So when we're thinking about this, how severely underfunded organizations like CSBs have been with Medicaid, because it's not able to encapsulate all of the different things that it requires when you're caring for somebody with a mental health. So we're able to actually have that reflected within those costs. For statewide data, I'm going to specifically focus on the state of Missouri. One, because it's a gold star when we think about CCBHCs generally. They've been super innovative and thoughtful as they're building this out. But also because they are a state and that uses one of the organizations that we partner with because of how innovative and thoughtful they've been with CCBHC, which is NetSmart. NetSmart, their care manager platform, is a platform that helps to pull that population health specific data and do it in a shareable way. The data that I'll be showing you here is what NetSmart has been able to help capture in partnership with the state to be able to show what CCBHC has been able to do. So Missouri increased access to care by 35%. Veterans are a population that they're required to focus on. Virginia has one of the highest populations of veterans in the country. So CCBHCs are required to provide veteran military services, have those partnerships. The degree of the partnerships are able to kind of work because VAs can be tricky. Partnering with the VA on that way, have those trainings to work and serve those populations. In Missouri, they increased it by 26%. When we look at the workforce recruitment, we look at savings, you can see that family support or peer supports significant increases, especially for those peers who can do a lot of different services. And if peers are currently not reimbursed in a fee-for-service structure here, they're built into the cost of your clinic until you receive that reimbursement for their salary or for their hourly rate. Psychiatrists, specifically youth, they were able to double, as well as looking at PAs and APs. So I will say that a lot of those youth psychiatrists were folks they pulled from Kansas clinics who were able to give them a more and better competitive. When we're looking at some of the data around emergency departments, so they calculated that about a $500 per person savings just on deflection and diversion within the. So again, the CCBHC can have its own salaried staff embedded into the ED, embedded into other crisis centers, embedded into the hospital system, embedded into inpatient facility residential care to deflect and divert when the level of care is not appropriate or potentially a hospital setting, ER, the bright lights, loud noises, folks in crisis may not be clinically appropriate for the individual who's being brought there. So they can take them to an outpatient setting with the appropriate clinical care and be able to meet them where they're at. That also reduces the impact on costs for those hospitals, reduces that burden, reduces that burnout. So it crafts that partnership. There are also ways, so one of the, and I know that NetSmart partners with this organization too, Bamboo Health. They have a program, I'll call it, again, not a tech person, called Patient Ping, where if an individual who is a client of the outpatient CCBHC is brought to an emergency department, it then pings them so they'll know in real time that this individual has been brought to the ED, so they can then understand, work in partnership, and meet the individual where they're at, provide them services, maybe share information with them and work in a way that can help to get them the appropriate level of care. So the NetSmart platform, again, what they're using Care Manager, the state as a state that philosophically focuses on limited government and not adding to government funds, the state crafted a partnership with the state association. And so the state association was able to add new staff, data scientists, experts without that kind of same bureaucratic work that a lot of state government has. They were able to hire folks, bring people on board, and kind of build out a whole team to manage statewide data governance, statewide data analysis, and work in partnership with their clinics to make sure that they were kind of targeting and getting that information in a way that really worked. They called it Clive. So here you can see kind of a snapshot of some of the data that they were able to pull. This is a couple of years old, I believe. And so you can see what they're able to do in real time. So what's really cool is that when they can also have this on their phones, they have it on their tablets. So when the folks from the association are in meetings with the state or they're in a meeting with the clinic, they can in real time pull this up and say, hey, we're seeing that, you know, you're seeing an increase in youth. Have you had conversations with the schools about what we can do to embed more care or provide more services? Have we thought about, so they can think in partnership to really react to the data that they're seeing and provide those services and give more and better insights. It also, when you work with the state, you can say, hey, we're seeing a larger increase in youth and adolescents who are needing care. Is it possible to allocate more funding to this? And so because it is real time, you're able to have more of a timely response. The clinics can also, if they have the flexibility within their payment structure, add more staff to be able to respond to that need or craft partnerships with other clinics to be able to meet that need should there be something there. We saw this happen in Michigan, where there was some unfortunate events within schools that took place there, and the clinics were able to work in partnership without running into the red financially to be able to provide those services just to the schools. So something that it can be hopefully being more reactive than having to allocate or create new line items within the state budget. Here is a patient profile specifically that you can see from Missouri that kind of helps to understand those potential risks related to the individual with when providing that clinical care. And this information also, in a way that's de-identified, is able to share an aggregate to the state so they can see within that catchment region what's actually needed and what's taking shape within those areas. So I talked about care coordination requiring that health IT component. And so the next couple of slides, I'm going to talk about that specifically, obviously for this audience. So just making sure that you all are aware of that. There are requirements for care coordination partnerships. And again, the clinic can include the cost of those partnerships, which includes sharing data, sharing technology to make sure everyone's on the same platforms or that those platforms are interoperable. So I'm just prefacing that as we kind of go through those slides to make sure that that's kind of relevant and sticking in. So as I mentioned before, the CCBHC is required to have partnerships, and it is allowable to be able to deliver services within the confines of those partnerships. So I'm a foster parent. So with CCBHC, there is a connectivity. We have an iPad that we can then work with we can work with CPS, we can work with the foster care agency to be able to, at no cost to us, be connected to the clinic in real time, where if our kid has an episode and we need to de-escalate it or we need more and better support, we can be able to work in that way to help and support that. You can also provide those services in the house. You can provide services within a school. You can provide those services within the justice sector, obviously not jails or prisons. If somebody is currently incarcerated, but if someone is being held pre-trial, you can deliver those services. You can screen them for a mental health substance use challenge, make recommendations in partnership with the public defender that person be in outpatient care. Oklahoma has been able to reduce the wait time for final disposition by 8 months, being able to do this. So some really cool, innovative things that we're seeing in some other states. So a lot of different kind of opportunities to make those partnerships happen. But it's really up to the clinic itself to do the legwork to make that happen. And then the state can help by supporting it and affirming their reimbursement rate to reflect it. So when we're thinking about health information systems, CCBHCs obviously are required to have the EHR. They are required to have demographic information, diagnosis, medication lists. They look at clinical decision reports that obviously help when we're working in partnership with their MCOs around reimbursement and the electric transmission of prescriptions to the pharmacy. Some CCBHCs have pharmacies or have a formal relationship with a pharmacy that's tied in with it. That data and quality measures, care improvement, and then obviously as well, data around outreach. So I mentioned that because within CCBHC, you're able to include the cost of things that are often not reimbursed or often not funded, like outreach. For populations who have a mental health or substance use challenge, it can take a much higher level of effort to engage, to retain them in care, to work with those populations, especially if folks are moving from place to place or maybe unhoused. So they're able to increase the cost of that, and then the individual doing that work is able to then share that, put that into the data system, and make sure that information is then tracked to inform the state, inform those providers on what may be taking shape. With population health management, again, this is really where we saw the work with NetSmart shine. So in Missouri, every clinic had a different EHR. They had a bunch of different kind of tech partners. But when they launched CCBHC, actually when they launched BHH, so the behavioral health homes, they decided that all the clinics would have the same population health management tool that was interoperable with those EHRs, that was able to kind of share and work in partnership with those data systems. So that way the association that was there, the statewide association, and the state could have that one place where they knew that these data would be shown in the same way, so they could make more reactive, responsive decisions. When we're looking at the population health tools, we're looking at that information, it captures in a real snapshot what the individual is experiencing, but more importantly, what the population is experiencing. So you can see, we have a higher number of youths with polysubstance use disorder within who are Latin or Spanish speaking. you're able to kind of get that more pinpointed focus. And then because it is tied in, you can have it in real time. You're delivering those services within 10 business days. And also you have staff who can do the clinical work and then staff who can do the data work. You know that there's a higher chance that the quality of those data are better. And it's also in more of a real time. So in Missouri, they're able to do this within a 48-hour period. So you know that if somebody is pulling those data today on Friday, it's as fresh as Wednesday, if not fresher. So it's something that's really important, especially when we're looking at population specific. You can also have that client tracking capacity, so notifying providers. I mentioned that example with patient ping, the quality improvement data. So there's a component and a requirement around CQI. And so when you're partnering and working with, when the state is partnering and working with the clinics, they can also help to identify and work with the clinic to figure out, okay, where and how are you going to be able to improve X, Y, or Z as relates to those services or as relates to that population. And also because of the CCBHC model, and there's even greater flexibility if the state gets into the demonstration, you're then able to share data, including those data, those allowable data within the parameters, right, 42 CFR Part 2, in ways that are interoperable. So making sure that you're able to work within those data systems, because when you are a DCO, the way in which the law defines it is that that is another clinical arm within that specific scope for that clinic. So if you're within the walls of that clinic, you're within that scope, the DCO is also in alignment with that. So it creates an opportunity to really tie in together a lot of those systems and a lot of that information and really connect the community in a way that it hasn't been connected before. From a population health management system for some optional areas. So primary care screening and monitoring is a requirement of the model. And so when we talk about it, you are screening those primary care services for behavioral health conditions, right? So if my client has higher rates or higher blood pressure, but I also know that this person has severe anxiety or bipolar, or if this person is using tobacco, and we know that this is also tying as a way to mitigate or as a harm reduction mechanism for opioid use disorder, we have more and better information to interfere that way, which may to intervene and support the client as opposed to what may be viewed in other types of care settings. So this is a list of some of the optional care screenings that you can include for CCBHC. Many clinics do. So the CCBHC criteria, as I mentioned, it was established in 2014 and then crafted in 2017. A lot has happened since then. We've seen reduced restrictions around buprenorphine access. We've seen reduced or better defined regulations around like methadone mobilities. 988 was established. So there's a lot of different things that have been updated in the criteria. And this next slide talked about a bit of a snapshot for it. So CCBHCs are required to have partnerships with 988 crisis providers. If your clinics are a 988 call center, you can include the cost of that call center in that PPS rate. So a lot of states that are like advocating for more and better funding around 988 call centers to be able to make sure that you're, having either like a percent tax or having something along those lines. This allows it to be more Medicaid related. And then when you're sharing and you have those partnerships, you're then able to track the information from call, text, chat, all the way to recovery and admission, which helps to make sure that it can see where and how the provider or providers in that area are really working well and being able to address the clinic's needs or the community's needs. For the opioid epidemic or overdose epidemic, I should say, requiring partnerships with OTPs, again, those methadone providers. It also requires the ability to add in those harm reduction or overdose prevention services, ones that are allowed by the state, obviously, that the state wants to provide, and also tracking fatal and non-fatal overdoses. We know that CCBHCs have been really innovative in helping to prevent the development or the worsening of a substance use disorder. But as we know, like fentanyl and polysubstance use is really taking a pretty heavy toll on communities. And so how can we more and better track that with that real-time data component to be able to craft more and better interventions to meet those needs? So having those data is going to be really important. And then from a health equity point of view. So I mentioned that clinics are hiring these 27 staff across the board. What's really powerful about CCBHC is it's also requiring that you are hiring folks who are of the community. right? So when I give this really great example in Utah, where there's a lot of folks who serve missions, they are Spanish speaking because they've served in Latin American countries, and so they've hired all these awesome Spanish speaking individuals who want to be able to deliver services, but they are not of the Latin or Hispanic communities that live in so the trust factor there is not as great as it could be if someone were of that community. So the CCBHC worked to be able to identify, one, who are individuals that we can then hire, what's the salary that's going to be really reflective of that intimate skill that they have to be able to work with folks. And they substantially increase the number of folks who are being seen, who are Spanish speaking, who are of those populations. So when we're thinking about health equity, CCBHCs are hiring folks of the community. And because that is an expertise, they are paying them as an expert in that community. And so it really helps to ensure a health equity point of view, as well as the other components that address those social drivers or that social determinants. Other key components, I talked about how those DCO partnerships. So the CCBHC only needs to be able to deliver 51% of those encounters, so other partners can deliver the other percentage of that, but that 51% is required. Before the CCBHC had to have clinical oversight of that other partner. Now there is this trust and requirement within those partnerships that they can have their own oversight. They're sharing those data and they're working in partnership with the CCBHC. They're also able to, from a needs point of view, when the state is crafting its criteria, the state doesn't need to do any additional legwork. It's the clinic saying what the clinic needs. The state takes those data in aggregate and then helps to inform that information. Here are the updated quality metrics. Previously, it was heavily on the clinic to pull all of those clinics for all these data components. And now the state is going to be requiring these from the clinic, but can work in partnership with other data providers, other data entities. I'm a social worker, but I'm also, I think it's the hurricane. Yeah, it's partially why I'm leaving after this. So with that, the state's collecting these data, they're working with the clinic to pull those data, and then you're able to have a more and better snapshot. As I'm a social worker, but I also do a lot of clinical research. I worked at Pew. APCDs are things that we would use all of the time as we were kind of validating a lot of the qualitative data that we would be receiving from patients. So what you're able to see here is that whatever the state can require collected measures, can add additional measures if it wants to. This is a floor, not a ceiling. Two more things about the PPS rate, but I'll just move a little more quickly. No, it's okay. I'm all right. Lesson. Is it? No, I'm sure it's just me coming from DC. But with this, so you can have a daily rate. And again, that's similar to what we see with FQHCs, having that daily rate. You can also have a monthly rate. A lot of states have a PM or a per member per month. So it's perceived easier for them to convert to that monthly rate. There's also a quality bonus payment option. So if let's say your state wants to more and better target a specific population or more and better target specific services, it can create that carrot so that those clinics are more incentivized to deliver those services, add those staff, and then be reimbursed for that quality bonus payment. We've seen this happen with justice-involved populations. We've seen this happen with youth services. We've seen this happen with a number of other populations and other types of services. So really innovative opportunities there to incentivize care. Here's a key difference between fee-for-service and that PPS. And again, this is PPS for a CCBHC. So across the board, some key differences here. But overall, again, the PPS rate is that bundled payment for what it actually costs to deliver services. That PPS rate is site-specific. So it would be different in Richmond than it is in Arlington, than it is in Charlottesville. So they would have a site-specific PPS rate, whereas that fee-for-service rate is going to be something that is more statewide. And then when you're, well, yeah, the highest PPS rate potentially, but that could also mean you have like the highest need, right? And so when you think about that highest need, but then highest cost, what we've also seen, I'll actually go back to this for a second. I know this also works. So in a state that we're working with right now, the clinic is actually using the salaries for Amazon drivers to be a comparable for what their baseline payment should be for peers. because there's a lot of folks with lived experience who are getting great benefits, who are getting, pretty flexible work-life balance, being able to drive trucks for Amazon and deliver those packages. But they need that talent, they need that expertise to be able to meet with folks and deliver that, person-centered lived experience or living experience. So when you think about that, if it is, if we're in Suffolk County and there's a much higher demand for staff, you then have a data point to then show this is what we're wanting to be able to do to make a baseline payment. I think in one state, it was in Kansas, they had it was like $12 an hour was what peers are being paid, and they doubled it. With CCBHC. So there's a lot of opportunity to kind of think about, where and how you want to have that PPS rate. But when you're calculating the PPS rate, whether it's a daily rate or it's a monthly rate, you are taking the entire costs of delivering care, of delivering the anticipated care to meet your community's needs. So being able to deliver services that are needed in real time, where folks are at, what is that going to cost? Divided by the entire number of people that you are going, or the entire number of visits, people on visits that you're going to be serving across that year time frame. So, and that's regardless of payer type, Medicaid, commercial, uninsured, out of pocket, like whatever, however you want to define it. So it's the entire number of visits. So you calculate that, and then you can get what your rate is. And so you are paid that whenever you serve someone who is medicated. So it is not reimbursing for folks who are commercial pay or uninsured, right? Because you're only paying it, but that payment rate is going to ensure that the talent you have on board is not at risk of losing their job, that the technology that you've onboarded, that you are using to share those data, you're not at risk of not being able to renew that contract. So it really helps to ensure that they can work effectively and have that solid revenue. CMS right now is working to update and finalize some proposed options. When we think about crisis care, there was a lot of funding that went to crisis care this last legislative cycle within Congress, including an 85% enhanced FMAP, which I had a slide that referenced that. I have to talk about it. This now allows you to have a crisis rate and your CCBHC rate if you want to go with PPS 3 or 4, which is a daily and monthly rate, but with a carve out for crisis. And I believe that's it. And I've got 20 minutes for questions or more time for you guys to have lunch. Any questions around CCBHC or anything along those lines? Was it a little clearer? Oh, yes. Oh, so the question was for the recording, are there any kind of national EHRs that are being really effective in helping CCBHCs be established? I know that there are ones that have been more and better partners with clinics and with national partners in doing that. I don't have them on the top of my head, but what we are often hearing is that regardless of their EHR, CCBHC can help to strengthen work. But it is going to need some adaptation to be more reactive responsive. So those are things that I think are going to be really important. But I can get the list of ones that we've known and highlighted. But that's a great question, a great point. Yes. Yeah. So part of what I was mentioning earlier about kind of staffing. So there's a workforce shortage, but a lot of folks are in private practice. So I'm again a social worker, and I know that if folks they kind of cut their teeth in the outpatient care setting, and then they went and started their own shop. But a lot of those doing your own thing doesn't often come with salaries or a benefits package or other structures or other things. Or you can also come back and work part time. So identifying and doing that research to figure out what's that carrot to pull people in from private practice. And also working with partnerships with other providers. So whether it's FQHC, it's OTP, other entities out there to figure out kind of where and how, what do you need to pay someone? What do you need to increase salaries within your own staff, change the benefits within your own team to ensure that you're increasing access to care. You can also build into the cost the partnership of technology partners who are remote providers. So a lot of clinics who initially didn't have like a buprenorphine waiver prescriber would have a technology, would work with, gosh, I forgot their name. It'll come to me in a second, but would work with a virtual prescriber or a virtual provider who could then do that, but was, maybe based in Vermont, but licensed in Virginia too. So they'd be able to do those kind of services to kind of meet those needs. But when it comes to that 10 business days, is getting them in and having them screened, and then be able to then work and follow up. So it's not real time delivering that care unless that person's in crisis and needs the services in a more specific way. But it can provide that opportunity to be really innovative and thoughtful when you're trying to figure out what is the kind of incentive to get folks in the door to actually be employees of that clinic, when it's a bit more. Yeah, I know. Looking forward to that drive back. But does that help to answer your question? So it is a bit of a science to figure out kind of what is it going to take to retain the talent you have at your clinic, but to also pull people in from other places. Is that helpful? And those partnerships with other technologies to do that work. Yes. Yep. Yep. Oh yeah. So actually, the state of New York, which is another CCBHC state, they hired HMA to analyze impact of CCBHC with it. And what they found was that it was cost effective for a few reasons. One of them was that not only were people having care being provided in a quicker, faster way before the disease developed, maybe caused complications, but also people who were receiving care were getting healthy. And so when someone's being brought to the emergency department, they're specifically focused on providing certain care in that kind of space. In an outpatient care environment, if you are being changed and I go over there, that helps to make sure that, like, one, we're meeting them where they're at, reducing any costs, creating. Yeah, yeah, absolutely. And I think what's more in my mind, what's also really important is because that's happening. Because as I mentioned, like clinical researcher for years, and I would be trying to create policy recommendations for a state in 2023 based off data I saw from 2019. So when we have those real-time data in a way, so you're able to better inform the state of what's necessary, better inform the clinic and what's really happening, inform the state. Because even right now, right, we're looking at things, and my expertise is more around substance use disorder. Like that's where I did all my work. When we're looking at a lot of the overdose rates, some of those data are really flawed because they're captured in different ways. With the CCBHC having those technology partners and being that one, make sure that it's a much more accurate quality to make more what really is the disease burden when they folks who have either just no opioid use disorder, polysubstance use disorder, dual diagnosis, right? So you're able to have a much better, clear vision. So something that just helps to better support the public and inform public. I have to drive back to DC. So, but you'll have my information. Feel free to reach out. Yeah. If anybody wants to go to Arlington, you're on my way.
So a couple of quick updates for your agenda. We are going to go ahead and try to break for lunch a couple minutes early because we've got that little bit of time, and we're also going to shorten lunch just a bit. And that's so that you guys can get out of here maybe by 2:30 or a little bit sooner than that. So the lunch and learn that was on there, we're going to move some of that stuff to the MC agenda at some point for those of you that are able to catch that. So we'll figure out how to work some of that in, but that'll give you an opportunity to get lunch. We'll go ahead and eat and we'll speed things up a little bit just so you can get out. I've looked at the weather. I don't think there's anything to be worried about still, so I don't want anybody to panic. You heard the phones go off, but they were doing that yesterday, telling us 36 hours from now you'll have a storm surge. So, but at your discretion, do what you guys need to do. I want you guys to all be adults, feel safe. I don't know where everybo's traveling to and all that. So you're certainly not locked in here, but you have to get food before you leave. Is the only rule because I'm not figuring out what to do with all the food. So I wanted to let you guys know that. I said all the stuff that you, I said all the stuff you were going to say.
Good afternoon, everyone. So I'm Glenn. This is great to be out here. So thank you all for having me out. Thank you to Brandy and to Brandon for inviting me out. It's always great to be the security guy and be the first person to talk after lunch. So we're going to try really hard to make this interesting and fun as much as possible, right? Security could be a little bit boring at times, but I try to liven it up just a little bit. So let me see if I can get the advanced stuff. All right. So here's the agenda. We're going to go over some stuff today. I'm not going to read it to you because I think everybody in the room can read on their own. We're going to go over some pretty cool stuff. We've been talking a lot about data today, and we have lots and lots of data. So what I'm going to present to you is what we're doing at DBHDS as far as the future of what we're going to be doing with data. Okay. So I always like to start out with a poll, find out who I'm dealing with in the room. So show of hands, who likes DC Comics? Yeah, so we have some Batman fans. Good. And Marvel Comics. Everybody else, right? Yeah. So thank you so much. Now I understand my audience, so I'll be able to be better prepared. All right. Okay, let's talk a little bit about data. So from a security standpoint, data has a few challenges for us. One of them is having data in lower environments. When I say lower environments, the dev and test environments. And when I came on as the CISO, one of the things I found very quickly is I'm starting to learn how to do my job. Oh, let me back up. I came on as a CISO for DBHDS in February of 2020. Everybody remember March 2020? Yeah. So I'm in the seat. What courts here? I was in the seat. What? Maybe 2 weeks. Maybe 2 weeks. I was just starting to learn how to even get to the office, and then it's like, hey, we're going to work remote. And Glenn, go for it. Have fun with that. Figure out the security stuff. Oh yeah. Where was home at the time. So, man, he's going to go really in. There's actually a slide later on about this. No, that's good. So I moved to Virginia from Alaska. And so I am in the seat, and the plan was that my family would stay there, finish up school, and then I'd go back and get them, and we'd all move to Virginia and happily ever after. That all changed, but we got through it. We did get through it. But as I'm going through the environment and learning my job and learning the people I deal with and what they deal with on a regular basis, I found very quickly that we had production data in our dev and test environments. And that's very risky because those lower environments are not secured to the same level as our production environments. Why is that? Money. It costs a lot of money to secure these environments. So that was one of the problems that we ran into very quickly. And then one of the other things that we found is sharing our data. We got all kinds of requests for our data. We still do that, especially from people in academics doing research and whatnot. It's so hard to give them unfederated access to our PHI and otherwise HIPAA data. But it would be so useful if we could do that. Think about what we could do if we allow all these researchers to have all this access, right? So as I started going through that, how can I, as the security guy, enable the business? And you'll hear me say that a lot, enabling the business, because how many people go to the security departments and what's always like plastered on the wall where they say, no, you want to what? No. And so it becomes very, it's hard for me to be part of that team if I'm always saying no. So I wanted to find a way, how can I say yes and get us the results that we really need and what we're trying to get at? So those were the problems and stuff that I was after. And one of the solutions that we came to was artificial intelligence. And this is where things get kind of tricky, right? Because artificial intelligence, a lot of people think is really new. Well, not really. Artificial intelligence has been with us for a while now. It's just now starting to become more mainstream. So whenever I say artificial intelligence, what do people think of? Chat GPT, right? Right, that's the thing now. Chat GPT is new Google for AI, right? So this slide, this is all the machine learning AI tools that are out there today, right? And so we call it MAD, Machine Learning, AI, and Data Landscape. And it's maddening. There's so much to choose from, right? So where do we even begin there? And understanding what your problem set is, what you're trying to achieve, those types of things. So we're going to go through each one of these one by one, and we'll find out which one's right, right? Now, so my question, another polling question, by show of hands, does your organization currently deploy an AI solution? So everyone says yes. Everyone says no. And then I'm not really sure. Yeah. So let's kind of delve into this a little bit more, and let's talk about the AIs and the different types of AI that's out there. So we're going to talk a bit about narrow intelligence, general intelligence, and then super intelligence. Because I think it's very important that we understand that tomorrow Skynet is not going to be turned on, right? But we need to be aware of what AI is, what it can do for us in the future, what the AI looks like. So we're going to start out with the narrow intelligence. So narrow intelligence is the machine learning portion of AI. This is where we're currently at today, right? Very good at doing very dedicated tasks, one thing at a time, right? And you see the things up there. So you have Alexa, Siri, and then does anybody know what that other little blue brown thing is? Cortana, Microsoft. It's actually Clippy. They just changed them a bit and made it look pretty cool, but it's still Clippy. But yeah, so it's dedicated to one single solution. So you ask it one question, it returns a really good solution for you, right? Again, everybody's very familiar with Alexa, Siri. Ask it like, I need directions. It gives you directions. You know, I need you to fold my clothes. It's not there yet, right? And that's where we get into what's called artificial general intelligence. This is where the intelligence goes from being machine learning to actual machine intelligence, where it becomes more human-like. And it actually does tasks as a human would do, you know? And so I don't know if anybody knows the picture I have up there. Yeah, I'm kind of a sci-fi guy. So as we go through this, you'll see some stuff, right? So this is where we have machines that we cannot determine if it's a machine or if it's a human being. That's how good these machines are going to be. This is very much so a concept, right? This is where we take all the narrow intelligence and have thousands of them connected together, working on single tasks, but it looks and feels like it's doing all these things as a human would be able to do. Cognitive abilities. Again, future. We are not there. Super intelligence. This is what everybody's scared of. You know, this is the Skynet. This is the how. If anybody knows 2001. So yeah, so these are the machine where it has consciousness, and it goes beyond just doing general human type tasks. It's able to think for itself. We are not here yet. And I say the word yet. A year ago, show of hands, who knew what Chat GPT was? Few, maybe, right? And then all of a sudden, within 3 months, it went from, hey, there's this neat thing out there to everybody knows about it, right? That's how fast this is progressing. Quantum computing. Anybody know about quantum computing? Everybody's heard about quantum computing, right? That's happening very quickly. And then when we start looking at the progression of the technology of quantum computing and the AI and what that's going to look like when we overlap that, that's when we're going to get closer to this, right? I don't think we're going to get to the point where machines are going to be killing us, I hope. But the key thing here is that when you start looking at super intelligence, these devices and machines will be able to do far beyond more than what the smartest human being on earth can do, because it's going to have access to all the data at one time and process all the data, right? Again, that's going to be the pinnacle of human achievement if we ever get there. I guess the question is, when will we get there? I'll think about it. As we start talking about the use of AI, it's very important we talk about the ethical use of AI. So what is ethical AI? I will tell you that going through and evaluating a lot of different solutions of AI, a lot of them are black box. What black box means is like, that's our secret sauce. You can't see that. We're going to give you an output, trust it, but you can't see what's happening there. Ethical AI is completely transparent. Whereas whenever you ask for something from AI in the machine, it gives you an output. It tells you how and why it came to that decision. And this all goes back to our data, right? We have to have good data that goes into these machines that we can trust so that whenever we do get an output, we can say, okay, why is there biases there? Do we have biases in our data? Why is it hallucinating, giving us a solution back that we know from our experience and expertise is not correct? Who has used ChatGPT? Yeah. How many times have you asked it a question, you get an answer back, and you ask it the same question in a different way, you get a different answer back, right? Okay, so how do we determine what the real answer is? We use our expertise and our experience to understand. What ChatGPT does not tell us is how it gets to that answer. And that's very critical, especially when we talk about medical care. So let's say that we ask the AI, hey, what is the best medical treatment plan for a terminal patient that saves both time, money, and effort for the physicians and for the patient? And that seems like a fair question, right? We want to be able to give them the right care at the right time, and saving time for the physicians, they can go on and treat other patients. But what if the AI comes back to, oh, in that case, let's euthanize the patient? That's in clear violation of our human ethics, right? So now we need to go in and ask the machine, okay, how and why did you come to that decision? And then we have to be able to adjust it so that we get it within our human ethics. Because these machines, these AIs, they don't have that innate built into them like human beings do. Another example that I read recently in a book about AI was using AI for strategic decisions, right? What if we ask it World War III type scenario, nuclear war, and how are we best to defend the United States and save the most lives possible? And it comes back and says, well, you know what? New York is pretty big and all, but strategically, it's not important. You can let it go. Would we, as human beings, allow millions of people to die because it's not in the strategic interest of our nation? I would say no. So we need to go back again and have a very clear understanding of the AI, how it gets to its decisions, and be able to adjust it so we can get the answers that we feel comfortable with. Again, that ethical AI piece. Any questions on the ethical AI? I get a lot of questions on ethical AI. That's why I want to pause. No, we're good. Okay. So this brings me to the next thing. How can we employ this AI, these wonderful super machines, to be able to solve the problems I posed at the beginning, right? How am I able to secure my lower environments with the production data in the lower environments, but also be able to share data with those who need it most to help push us forward in our quest for better care for our patients, right? So synthetic data. So how many people are familiar with synthetic data? Expert. Somewhat. And how about just nope? Yeah. And then that's not surprising. Synthetic data is something that is somewhat new. Gartner produces a hype cycle chart every year about different technologies. And for the past 3 years, synthetic data is at the very top of the hype cycle. What does that mean? It means that it's really hyped up. People have all these great ideas how it can solve things. We haven't got to that trough of disillusionment into the real world of what it can do for us. But it's out there and it can solve a lot of issues that I found in my organization that can benefit us. So what is synthetic data? Synthetic data is not real data, right? By definition, synthetic. But it goes beyond that. You can create a synthetic database or a synthetic data set that is a true representation of production data. And that's key. So I'm going to hit on that a couple of times. Keep kind of marinating that, thinking about that, right? A true representation of your production data that is valuable, but we don't have the implications that we have with our production data, right? And the great thing about synthetic data sets is that you can scale this to any size you need or want. So we talked a little bit earlier in one of the other sessions about machine learning and using COV data to teach those machines. Having good quality data at scale is hard to achieve, but we can create it based on production data. So synthetic data is a very abstract concept. So this is a picture of my family, and I use this as an analogy of what synthetic data is by enlisting their help. Okay, so just bear with me. So this is my wife, Bianca, my two boys, Wyatt and Aiden, and that's me. This picture was taken in Alaska right before we moved to Virginia. That is not a backdrop. That's actually up in the mountains. That's up in Hatcher's Pass. My wife loves fall pictures. We actually we booked that about 8 months in advance. The morning we got up, it was cloud covered, overcast, and I'm like, this is not going to be good. And we had a backup date the next day. We get up in the mountains and you can see it's clear skies, had a great day up there. The boys had a good time. The very next day, they had 4 feet of snow. So it all worked out for us. This is my family. Something the key takeaway from this, we're very diverse. And I say that because I was born in the United States. No one says I'm from Arkansas, but I am. I joined the military. I spent a lot of time overseas. My wife is German, so she's born in Germany. My oldest son, Wyatt, he came to us while we were in the United Kingdom. And then my youngest son, Aiden, came to us while we were in Portugal. So I think it's very important, and we consider ourselves global citizens because we travel a lot and we want to make sure the boys are exposed to other cultures. But we're global citizens, and just like our patients and people that we serve, they're very diverse as well, right? So now that you met my boys, how many people have kids? This picture will probably resonate, right? Laundry, lots and lots of it, especially when you have two boys. That's all, it's just nonstop, right? This is representation not only of our laundry, but our data. We have so much data, mountains and mountains of data out there. And you think because we have so much data, we have all these insights into treatment plans and how our patients react to certain things. And we would have all this knowledge, but we have data. And there's a difference between having data, information, and knowledge. And right now, I see it, we have all this dirty laundry, we just piled up, and it's not helping us, but we have it, right? How many people whose kids have their favorite baseball jersey and they're yelling, "Where's my jersey at, Mom?" You know, and it's somewhere. We know we have it. It's somewhere in this big pile of stuff. So how do we go about cleaning our data and being able to present it and understand and know what we have? And that's where we're going to use AI and help us with that. So dirty laundry, right? Nobody wants to have anyone have access to our dirty laundry. Same thing with our data that's not cleansed, right? And when I say cleansed, it's not obfuscated, it's not de-identified. And that's where it comes really hard to be able to share that data with the people who really need it most. Other physicians, other partners, and academics, you know. How many lawyers do we have in the room? Okay, good, because data sharing agreements. Oh my goodness. Words mean things, guys. And I've learned that, as I said in data sharing agreement meetings and have to redline things, at the end, the words are on the paper. I don't know what they mean anymore because the lawyers have changed everything, but we have to do these. And we have to have an understanding from a security standpoint that when the data is no longer needed, it gets destroyed. And I have to trust that the person who signed this piece of paper, they're going to destroy that data. I have no way of verifying that other than you got my word for it. We did none of that. So how can I take my dirty laundry, make it presentable in a way that I know is going to be nice and safe? And what we have done at DBHDS, we searched out, we found a solution that is an AI that can take a production data set and make a synthetic data set that's a true representation of the data, but it's completely clean, right? There's no PHI anymore in it because it treats every data point as private and it changes each one of those data points so that it's still a representation, but it's clean. So now I don't have to worry about somebody come look at my dirty laundry. I have things folded up, right? Nice and neat. And now we can build a wardrobe. So now we can pick and choose, and we can truly understand what we have. Going from that big mountain of dirty laundry, the big mountain of data, to something that is truly knowledgeable. And we can build insights into that. We can analyze it. We can understand what our treatment plans look like. What are the best treatment plans for certain individuals? What is the predictability of a certain outcome? And then more importantly, now that we know this type of data is synthetic, we can inject other data sets, right? How many people struggle with trying to understand and predict what their needs are going to be in the next 10 years? Probably like everybody, right? What if we had a way to inject census data into our data sets and create a data set that's a representation of the future? And no longer are we just crying and screaming, hey, I need more money to do this and this. We now have empirical data that back us up, saying this is what our demand is going to be in the future, by region, by city, by county. How great would that be? Now we can go back to the General Assembly and say, for certain, this is what census is saying, this is where we're currently at today, and this is where we're going to be at in the next 3, 5, 7, 10 years from now. With the AI and the synthetic data sets, that is now possible. We just got a request from the Secretariat of Health and Human Resources about just that. Can we predict what our demands are going to be bed space wise in our facilities in the next 10 years? And that's hard to do, but we have data to help us with that. And so we're going to look at using this AI to do just that for us, to do all that analytics, because that's going to be a lot of hard stuff that is going to take a lot of resources. How many people have unlimited amount of human resources to help do that? Yeah, I have 5 people on my team. So I can only imagine what it's like for you all trying to accomplish what you're trying to do, right? So this is where it gets tricky, because everybody's like, yeah, Glenn, that shirt that your son wore yesterday, I know it's your son's shirt, but I saw him wearing it. How many people donate clothes when their kids outgrow their clothes, right? The ones that are still good, not the ones with the holes in them, but the really nice ones, right? And we do that. And when we see another child wearing those clothes, that child is not my child. No one ever confused that child as being my child just because he's wearing my son's old shirt, right? That's the beauty of synthetic data. It allows us to do those things, right? So now this is where I was like, give me an example. It's very abstract, right? So, but here we go. So production data, everybody, I'm going to assume knows what production data is. It's something like here, names, addresses, dates, anything that is in a structured form, we can do this. It can be large, it can be small. And here's an example, right? It's just nothing super fun to look at, but it's got all the stuff there, right? Addresses, we say phone numbers, date of birth, whatever. I think in this example is about cars, so it's got license plate numbers, those types of things. So with the AI to create the synthetic data set, it looks at the original production data. Again, it looks at each individual data point and assumes it's going to be private, so it's going to change it. And this is what it looks like now. And that's when I normally get the, ooh, no, not really. It just changes stuff, right? But what's really neat about it is this next slide. This is the representation, right? The synthetic data versus the production data. The structure is still there. So whenever we take this and we're able to give it to people to analyze, there's no impact on the analysis of the data. How powerful is that? Right now, I can freely give out this data to anyone that wants it. They can do any analysis they want to on it. Oh, and if it's disclosed, okay, it's not real. We don't have the compliance issues anymore. All of those long, drawn-out data sharing agreements that we've had to do in the past, we don't have to worry about those. Now we can start focusing on data usage agreements. I'm going to give you access to this, and this is how you're allowed to use it. And if you violate that, you won't be able to use it anymore, right? So next polling question. Who's still with me? Yes? No? And who the heck is this guy up here? All right, I'm glad we're all still together. Okay, so now we get to talk security stuff. Yay! So what is the point behind synthetic data when it comes to security? And for me, I've solved one of the problems of the production data in the lower environments. So does anybody understand why we have production data in lower environments? I'll tell you, because the business has a say-so. The business likes to have good quality data sets they know, so that when it goes into their test environment, they know what the output should be, right? What if I give them a synthetic data set that is the same thing, but we don't have to worry about all the compliance pieces? Now we don't have to secure those lower environments to the same standard, don't have to spend all that money that we could use for something else. So that solves that problem. It also reduces our risk, right? We'll do some simple math real quick. Let's say that the average data breach from ransomware is $3 million, which is about right. Top to bottom, $3 million per incident. Let's say you have 10 production environments, right? So that's $30 million worth of risk. Oh yeah, you also have the lower environments to go with that. So that's times 3 again. That's a lot of risk that you're carrying. So by replacing those systems with synthetic data, you've drawn down the risk. Going further, if you're using systems that are solely just for analytics, why wouldn't you want to use synthetic data set there as well? Now you've reduced that risk to 0. How wonderful would that be? Now you can use a system and you have 0 risk. If you get hit with ransomware, what happens? In a traditional sense, we got to figure out what data do they have? What's the sensitivity of the data? Or we need to notify compliance organizations because we've got violations of HIPAA. You know, those types of questions start being asked. But if we're using just synthetic data in a virtual environment, we can just delete the machine. Okay, we spin up a new machine, we produce a new synthetic data set in a matter of minutes, and we're back up and operational again. That's the beauty from the security side of it, right? And a lot of people, when I talk with the security guys, the light bulb comes on, right? Now I'm no longer a burden to the business. I can enable that business and I can help the business save money. And that's what all security guys would love to say. I saved the business money today, because normally, traditionally, we don't do that. We spend the money, right? We talked a little bit about machine learning. The difficulty of having good quality data for the machine learning piece. AI is here, and it's only going to advance more. And we're going to bring on more and more AI products and services into our environment. You saw the slide with all the ones, right? Think about if you bring on one of those and you have to train that AI, how are we going to be able to do that? Synthetic data, in my mind, is the right way to do it, because now we can generate a good, large, at scale data set, and using the AI, we can look for data quality issues. We talked about that earlier as well. Now the AI can identify those data quality issues and it can automatically fix it because it's a synthetic data set. It sees, instead of, say, a birth date is incorrect, the wrong format, it knows that's supposed to be a birth date. I'll put a birth date in there. So now we have at scale machine learning data models. Now we can get our AIs up and running quicker, enabling the business faster. Implementation. So this is more geared towards the security guys when I talk about this, but I think it's important for everybody to understand is that understanding your approach. For me to go into a meeting with the executive leadership team and say, I need more money for security, because more security is what we need. They're gonna like, yeah, whatever. But if I go in and say, hey, I have this idea and there's a solution out there to help protect us, but also it's going to enable the business and tie it back to the business, because it's all about the business, right? I don't exist to exist and everybody else supports me. I exist to support the business. So understanding that from a security perspective is that it's not about me, it's about the business. Most importantly, understanding the timelines and your objectives. And Court's here, he'll back me up on this. Before we made any decisions, we set out, these are our objectives that we want to be able to achieve. And we talked to the solutions vendors and said, can you help us achieve this? We found one that could do all those things. We didn't say, hey, we want this tool set, let's get it in, and then try to figure out how we're going to use it later. We were very thoughtful in how we went about this. And then understanding that return on investment. We already talked about the ransomware piece, right? In order to be able to deploy something, you got to put it into a perspective that most people understand, and that's money. So when you're able to talk about the ransomware threat, what it would cost the business, what's the overall risk that we're carrying in the money sense, the people who hold the money, the CFOs, they understand that. Oh, let's drive down that cost. So you're able to secure the funding that you need for that. So this is our objectives. We set out 6 phases. First phase is the creation of the data sets to get us out of the dev and test environment problem, right? Because I'm the security guy. That's my main concern. So that's number 1, right? And then the creation of the synthetic data sets to analyze and help identify data quality issues. That's like, to me, foundational. Until you get your data sets right, the rest of the stuff that we're talking about is not going to happen. So let's get our data quality right. And then we start looking at the analysis piece, right? Now we can create these synthetic data sets and release them to those who can do all the research for us and really start pushing the envelope of treatment for our patients that next level. Again, that knowledge base as opposed to just having data. And then we can look at treatment outcomes. You know, what is the best treatment outcome for this patient? And we can ask the AI and we can put in the certain parameters of a patient and they'll be able to tell us these things. And then the predictability of the likelihood of a successful outcome of a treatment plan for patient X by putting in the specifics behind what that patient has. And then we talked about phase 6. That's where we start looking at the future. How can we use the AI and leverage it to help us understand what our future landscape looks like? How can we prepare to be able to meet that? And then my final slide, come on, there we go. This is our final polling question. What is better, Star Wars or Star Trek? And this has been the question that needs to be answered since like 1970. So if somebody can help me answer this, Star Trek, yeah? Apples and oranges. So I love it. Now we get to the real conversation, right? This is actually a question I had when I interviewed for a job in Alaska when I retired from the military. And I went to work for a bank. They asked me this question. And they're like, hey, final question for your interview. What's better, Star Trek or Star Wars? And I was like, I really want this job. And so I went into dissertation, the pros and cons of both, the way we view things in my house. My son is a huge Star Trek fan and a Star Wars fan, but we went through the whole thing. At the end, I said, so in conclusion, it depends on your point of view. And of course, everybody kind of laughed about it. And they're like, that was just a fun question. I get it, but I really want this job, So I did get the job. But yeah, so that's it, guys. I compressed a little bit because I know that we're trying to get out a little bit early. But any questions? Yes. Okay. So the question is, let me get this right. The question is, how can you convince your vendors to move to a more secure state? Okay. So my question, I like to answer questions. Okay. So my next question to you is, who pays the vendor? Where do they get their money from? Then you can demand to them, this is how it's going to be done. It is the truth, because if they don't do that, then they don't get paid, right? Well, and this is my perspective on that, right? Is that, okay, if you don't want to do that, that's fine. When is your contract up? In 2 years? Now's the time to put the RFP out and get a new vendor. The thing is that you guys, you should be able to control that, right? It's your data. It's your data, not theirs. You should be able to dictate to them, not the other way around. But I'd be happy to talk with you a little more offline about it if you want, but that's my perspective. Yeah. And that you should stipulate that when you renew the contract. No production data in the dev and test environments. And oh, yeah, yeah. Yeah. Well, let's go back for a minute, right? Ask the vendor this: Are those lower environments protected and secured at the same level as the production environment? And if it's not, say, okay, well, why isn't it? And then say either you do it this way with a test set data in those environments, or you have to protect it at the same level. It's their call. And then they have to spend their money. Mhm. And I agree with you 100%. My whole thought process is test environments, dev environments require test data, right? Because our production data get hit all the time when we get hit with ransomware, right? So just securing to that level doesn't guarantee you won't get in trouble. It reduces the risk a bit, but I don't know. You own the data. That's your data. The vendor has to do what you say, or they're not going to be your vendor anymore. Yes. Yeah. I'm with you. Yeah, because it's cool. Mm-hmm. Yeah, absolutely. I'm not going to sell a particular vendor, right? We have a vendor that we've decided to have a strategic partnership with, and I'll be happy to talk with you offline about it. There are some free resources out there that can do synthetic generation. It's pretty neat for the nerds in the room. I'm not a data scientist, but I'm kind of a nerd. And it's all based on Python, and you can put in certain parameters and it will generate a synthetic data set for you. Or you can take a production data set or a data set you have and inject it into that model, and it can generate synthetic data for you. But I have all that stuff. I'll be happy to give that to you. I just don't know off the top of my head that is, but there's website stuff you can go to do that. Yeah. Yes. I'm going to say no. It's not the same. And when you talk about de-identified data, you're changing certain data points, right? Like last name, date of birth, social security number, but you're not changing all the data fields on all the data points. Synthetic data is a complete change of all data points so that it cannot be re-engineered back to the original. They used to say you needed 5 data points to be able to re-engineer back to somebody. Now it's down to 3. So all you need is 3 data points, and you can re-engineer it back to a live person, right? And with the synthetic data set, and I always use this example, right? My dad, he's 71 years old. He lives in Logan County, Arkansas, and he drives a 1974 pickup. There's only one person in Logan County in Arkansas at 71 years old drives a 1974 pickup, right? So with the data sets, the synthetic data sets, you can account for that, right? So then instead of having just one person, it may have 5. But it also takes that into account whenever we showed the description of the 2 types, right? Of production data versus the synthetic data and what that would look like. It takes that into account. So there's some outliers there as well that you can compensate for. Any other questions? Yes, sir. Mm-hmm. Is this what you're talking about? Yeah. So when we built this out, we wanted to kind of baby step through this, right? And so phase one is very entry level, phase one type thing. We found very quickly that phase 6 is in band. So how do we do that? Right? We're not mature enough to get there. So having a great partnership and relationships with our vendor is very key. Went back and talked to them about it and said, hey, this is something that we've been asked to do. We know we're not mature enough to do this yet. Can you help us? And the answer is absolutely they can. The thing is like, does it have PHI information in it? Because our vendor does not want to have any access to any PHI information. That's what's great about the vendor relationship I have. They don't want our data. They've given us the solution and said, you can run it on your systems. We don't want access to it unless you give us access to it. And so they're going to help us with that. So we're still early on, very early stages of this, and but it holds a lot of promise. I've got a lot of interest in this. I briefed this, a very similar presentation recently at the Commonwealth Information Security Conference. And there's a lot of people that are very interested in this. A lot of other agencies see value in this. So it's coming, AI is here. How do we best leverage the tool set? And I say tool set because I see AI as a tool. It's not a replacement, right? Everybody's so fearful that their jobs are going to be replaced. And I'm going to say, no, your job's not going to be replaced. Your position may get replaced if you don't know how to use the tool sets that are going to be required. And that's where the AI comes in. And we can have a whole nother conversation about generative AI and those types of things. I've sat on several panels the past few months on that. It's very interesting what's going on out there. DBHDS, we do have a draft policy about the use of generative AI, and hopefully I can get it signed soon. Because here's the thing, right? And I talked with a lot of CISOs, and we had a conference this week, and a lot of CISOs said, we're not using it, we're cut it off. Nope, not using generative AI, it's too risky. My approach to this is a little bit different. I know that it's being used today, and I know people are going to use it in the future. How about we put some guardrails out there so it's used in our environment where we know our environment is secure, as opposed to exfiltrating data out, putting it into their home computer, doing the calculation through ChatGPT, pulling it back and putting it back into our system. So we're going to put guardrails around it. I would be very hesitant to ever tell anyone to say, no, you're not using it. Because as soon as you say, no, don't press the red button, that's what they're going to want to do is go push the red button. Yeah. So, thank you. Any other questions? No? All right. Oh, one. Yes, sir. Okay, so the question says, I presented this to data vendors and the reaction I get from them. I have not presented to data vendors that I knowingly did so. And I say that because this presentation, this exact presentation I gave at ISC Squared. ISC Squared is the credentialing authority for cybersecurity credentials worldwide. I presented it there. My very first, I'm not a data scientist, that's my disclosure. This is just kind of a story what we're working towards. So to answer your question, I don't know if I have, right? But I do know that after I've presented this, there's a lot of buzz about it, and people have come back and asked me about it, what we're doing, and some more use cases. And Court and I, we talked about this quite a bit as we were going through this, and we sit and we think about, well, what about this? Could it solve this problem? Don't know. Go back and ask the vendor. Yeah, we can do that. Sure, yeah. And then talk with the engineer, and they show us how they do that. There was one case where I asked, can you do it? And they said, no, unfortunately, that's beyond us. We can't do that yet. So, my point of that is as you're thinking about things and being thought leaders out there, push that envelope a bit. We need to get to the point to where, no, the technology's not there yet. That's where we need to be. Not, well, how can we do with what we got? Let's push that a bit. Any other questions? No? Okay, well, I'll be around if you want to talk about things, especially security. No, nobody wants to talk about security, but I appreciate it. Thank you, everybody. I do appreciate it.
Glenn, thank you. Really good job. Everybody is still awake.
Yay!
Good. So you took the mission and you accomplished it. Couple of things. I'm contractually obligated as the DMC co-chair to not compliment DBHDS on anything. But what I do want to say is that we're joined by quite a few excellent representatives from the state agency as well as from our CSBs today. So I want to say thank you to everybody that's in the room. Glenn, that was awesome presentation. I think some good information for all of us to have and to be able to reconcile. So I want to say one positive thing about where we're at, and that's that the people that are in this room today are the ones that do make this spaghetti diagram type of stuff go away. And we have the people, we have the intelligence in this room and the knowledge and the wisdom to do it. And that's what's exciting for me about where we are in the state of Virginia. If you would have asked me that maybe 5 or 10 years ago, I don't know that I would have said the same thing. I don't know that I would have said the same answer that we could get from point A to point B. We have the people and we have the resources and technology to be able to do it. We're working on gathering all. So when we started to talk about getting this summit together, it was a first step, right? This is the first step in a couple of series of steps that we've got to do, because we recognized that we don't have, we haven't brought all of our workforce along the same way we have our clinical workforce. So the more that all of us are aware of the opportunities that are out there, the resources that are out there, and the technology that's there, and who in this room we can network with to talk to and figure out those solutions back home or for the state, the better off we're all going to be, the less stuff we're going to recreate, the more things we're going to take advantage of, leverage, and move us a little bit further forward.